the thanks for hitting the record button. I'll start over. So good afternoon, everyone. My name is Madhavi Reddy. I'm the team lead for the Pediatric Mental Health Care Access Program at the Health Resources and Services Administration, Maternal and Child Health Bureau. I'm also a senior public health analyst in the Bureau with the Division of Maternal and Child Health Workforce Development. So it's really my pleasure to welcome all of you to today's half-day virtual all-awardee webinar. We're really excited that so many of you are joining us today. I also want to just thank both the PMHCA and MDRBD awardees for being in attendance. It's great to see that we're able to make space for from awardees from both programs to attend and to participate in today's webinar. So I would also like to, I'll give a short welcome today, and then kind of quickly go through the agenda for the webinar, and also address a few program highlights or program updates. So we're also going to have the pleasure of our TA providers joining us today. That includes JBS International, the American Academy of Pediatrics, School-Based Health Alliance, and the Emergency Medical Services for Children Innovation and Improvement Center. So JBS International represents the TA Innovation Center, and they will be our TA provider for the next few years. So they'll be helping us with general TA provision. For the expansion awards, that's where we have the assistance of the AAP, the SBHA, and the EMSC Innovation Improvement Center. They will be, helping you all with TA in the areas of, expansion into EDs, into schools, and there's also probably some general expansion efforts where they will be able to help you. So we're going to hear a little bit from them, a little later today about their plans for TA. I just want to acknowledge that it's a really busy time of year for you all, even busier with the addition of the expansion awards that I'll talk about in a couple of minutes. I just want to say for the PMHCA awardees that accepted expansion awards that, we want to thank you for doing that, to seeing, that there are areas of need where you could expand into. To reach, even more providers with much needed services, and also in turn, improving access to care for underserved children and adolescents with behavioral concerns in your areas. I also want to say that we acknowledge that both you and the providers that you support are probably dealing with new and reemerging challenges in the pediatric population. Right now we're talking about like rising cases of RSV, rising cases of the flu. We're seeing, pediatric hospitals and practices being inundated with cases and for both RSV and the flu. Your hospitals and practices are at capacity. So we just want to, hope that you and the providers in your programs are taking time for self-care in the midst of this new onslaught. Provider and staff burnout, as well as staffing challenges, continue to be a key issue. So, really please keep your HRSA project officers apprised of any areas of concern related to burnout, staffing challenges, so that we can provide the best support that we can to you. Now that I'm going to quickly go over the agenda. As you can see, we're going to start with a few program updates. Thanks, Jordy, for changing the slides. We're going to start with a few program updates. We'll have the 5 new PMHCA awardees that we awarded in 2022. They'll introduce themselves to you all. Then we'll have some introductions from the TA providers that I mentioned at the top. They'll introduce themselves and talk a little bit about their plans for the year in terms of TA provision. Then we'll have a short break. Next slide. And then after the break, we will turn to a presentation from our friends in Rhode Island who represent the Rhode Island Moms PRN and PDPRN programs. They're both located in the Psychiatry Resource Network that these programs created in the state of Rhode Island. So it'll be nice to hear about how they cross collaborate and their policy, some of their successes and challenges, but also, like I mentioned, some of their wins that they've seen in both the policy and partnership fronts. So I'm looking forward to that. And then we'll end with a session from 3 awardees who will talk about policy and partnership wins. And they're actually a mix of PMHCA awardees, both seasoned awardees that we funded in 2018, and then also a newer awardee that we funded in 2021 in the state of Georgia. There should be a little time at the end of the webinar for Q&A, but feel free to submit your questions in the chat box during sessions. And if we have time, after the presenters have presented, we'll try to go ahead and answer, address those questions if we have time. But please feel free to enter questions at any time in the chat box. We're also, as a reminder for speakers and for all of you to be aware that HRSA staff will provide a verbal 2-minute warning during presentations so that we stay on track with time, because we have a lot of presentations and a lot of slides. So just be aware of that cue. I just want to close by thanking the PMHCA team, Kara, Jordy, Katie, Kelly, and Patrice for their nonstop efforts on your behalf. It's really amazing to work with them on a daily basis. I'd also like to thank our grants management team that works with you all on budget, questions and concerns. And then I also want to thank our division and deputy division director, division and deputy division directors, Lauren Raskin Ramos and Hey Young Park, for championing PMHCA throughout HRSA and beyond. They're really incredible to work with, and and just all of the efforts that you've seen on behalf of the program have been thanks to them and to the team. Next slide. So for program updates, just want to thank you all, the PMHC awardees who accepted expansion awards once again for your submissions. They were due October 30th, and we've received many submissions. And if project officers and grants management specialists are in the process of reviewing them, if any changes need to be made, we'll get back to you as soon as possible. For those who need an extension, hopefully you have already been able to submit that extension request in the electronic handbooks. And if you haven't, please do that as soon as possible. And I believe each HRSA project officer has informed awardees if they need an extension, how to request an extension. But if you have any challenges related to that, just reach out to your HRSA project officer for assistance. Once you submit your project work plan and your budget, we, again, as I mentioned, will review and approve them, and you'll get notification once they've been approved. So also, we're also working with the grants management team to issue new notice of awards that reflect the 20% non-federal cost sharing matching requirement for the expansion awards. As many of you noted, that unfortunately the 20% match was not reflected in the initial NOA. And so we're working with grants management to get those NOAs issued as soon as possible. So we just want to thank you for your patience with that. I know for the 2018 and 2019 PMHC awardees that you all are probably thinking deeply about the fiscal year 2023 PMHCA notice of funding opportunity that's looming on the horizon. If you choose to compete again, which we hope you do. What we can share now is that the HRSA team, the project officers, leadership, we're working on the NOFO, and we expect to make 36 awards. So comprised of that 36, we may be able to make up to 15 new awards and have 15 new award recipients. So that's the number of awards we're looking to make. Also, just to let you know, the 20% non-federal cost matching requirement will remain. We're hoping that the NOFO posts on February 13th, 2023, and the closing date for applications will be May 15th. As with, anytime there's a lot of, HRSA NOFOs get extensive review, there's lots of rounds of review. So, some the dates may be adjusted a bit, depending on the review process, but, as adjustments are made, usually notifications are also made in grants.gov in the forecast section. Also, I just wanted to let you know that, JBS is in the midst of their national program evaluation for the 2018 PMHCA and MDRBD and 2019 PMHCA programs. We're in week 5 of the healthcare provider and practice level survey administration. So there's still a few weeks left for providers and practices to complete surveys. JBS has been really great about sending weekly updates to awardees about how you all are faring with survey completion to date, and also letting you know how that compares to your final survey response rate in 2021. Just keep looking for those reminders. I know that, again, there's so many competing factors going on for providers and practices to complete surveys, but if you can do what you can to use a promotion packet and other efforts to encourage survey completion during the remaining weeks, we really appreciate it. Just also a reminder that JBS will host their first evaluation capacity building webinar of this contract year on Wednesday, November 16th from 3 to 4:30 p.m. Eastern. So this webinar is going to focus on presentations from PMHCA and MDRBD programs in 3 states. So they'll highlight their experience working together and lessons learned from the utilization of some same partnerships and how that facilitates their collaboration. So you'll be getting a taste of that today with the Rhode Island presentations, but then you'll also hear more about PMHCA and MDRB collaboration on the next JBS webinar. Also, just some reporting updates for the 2018 and 2021 PMHCA awardees. A federal financial report is due on January 30th, 2023. When you submit that federal financial report, you can submit a carryover prior approval request if you have unobligated funds available. You can submit that at the same time as the FFR. As a reminder, the carryover prior approval request is submitted in electronic handbooks. If you don't submit the carryover prior approval request at the same time as the FFR, you have up to 30 days from FFR submission to submit the carryover prior approval request in the electronic handbooks. So if you have further questions about that, reach out to your HRSA project officer. And then for the 2018 and 2021 PMHC awardees, there's a NCC performance report due in EHB on January 28th. In mid-November, in a couple of weeks, the HRSA project officers anticipate uploading a request for information in your grant folders for year 4 data for the 2018 awardees and year 1 data from the 2021 awardees. So stay tuned for that. For the 2022 PMHC awardees, you will notice that there's a new competing performance report due on January 28th. In EHB, as well as a request for baseline data. So if you have questions about the reports, the requests, again, as I mentioned, reach out to your HRSA project officer. Finally, just want to remind everyone that we'll be hosting our first ever in-person all-awardee annual meeting in Rockville on March 27th and 28th. It's been a long time coming, so we're really excited about it. More details to come. Each program is encouraged to send up to 2 personnel to the meeting. If you have questions, reach out to your project officer. And just want to thank Kelly Hughes and Jordy Snyder for taking the lead on our side for meeting planning thus far, and also the efforts of our meeting planning super group, which includes many of you who have stepped in to help with meeting planning. And then down the road, as our TA Innovation Center at JBS gets up and running, they'll be helping support meeting planning as well. So just want to say for JBS, get ready for meeting planning. It's coming your way soon. So now I'm going to turn things over to Kara to introduce our first session where we hear from our 2022 awardees. So thanks everybody and looking forward to a good afternoon.
Thanks so much, Madhavi. Hi, everyone. My name is Kara Dela Cruz. I'm one of the project officers for the PMHCA team. And it's my pleasure to help facilitate introductions for our 5 new awardees who started their period of performance on September 30th, 2022. So it's only been a few weeks. So each awardee will just take 5 minutes to introduce themselves and their team, their location, and some high-level project highlights. And as Madhavi mentioned, in the interest of time, I'll just jump in with a friendly verbal warning when you have 2 minutes left of your time. So I think we're starting off with the University of Arkansas system, and we have the project director, Dr. Christopher Smith. Are you ready, Dr. Smith?
Yes, I am. Thank you, Kara. I appreciate it. We're very happy in Arkansas to introduce another champ into the process. I understand we'll have to be called baby champ at this particular point, but we're happy to be able to join Mississippi, our next door neighbors in this. Next slide. So you can skip this, but we wanted to we want to let people know when we're presenting this where we got funding from. So this is the acknowledgement slide. Next slide. This is our organization. So our CHAMP program is being sponsored by the University of Arkansas for Medical Sciences and with the collaboration of Arkansas Children's Hospital and a sub-award there. So this shows how we're organized with me as the co-director, administrative co-director, setting up our advisory board, and then coming down to setting up our CHAMP team, which will then organize our CHAMP sessions and CHAMP consultation. We will use CHAMP liberally throughout the presentation, but this is how we're organized to accomplish our goals. Next slide. So this is our CHAMP administrative team. I am the PI and the medical co-director, and then we have an administrative co-director. We have an evaluation and curriculum specialist and our grant manager from Arkansas Children's Hospital, as well as Suzanne Allstat, who is our program contact from University of Arkansas. Next slide. This is our clinical team. So I help coordinate that. We have a population health specialist. Natasha Bottoms is our child and adolescent psychiatry, Rachel Wingfield in psychology, and we're in the process of hiring our case manager. Next slide. Then we have an advisory board from organizations throughout the state. I will not go through all of these, and I know you're happy with that, but just to show that we do have a large coalition that is really going to be helping make sure and ensuring that this is a successful program. Next slide. So typically, why CHAMP in Arkansas and this particular thing? Arkansas, as most people know, is probably is a very rural state. We have a very high degree and growing of mental health issues in kids. Arkansas has the highest national rate of children with more than 1 ACEs. And so we have seen this rise over the period of time. And we know that in the state like Arkansas, we have racial and geographic disparities in healthcare and including mental health care. Next slide. So Arkansas Children's Hospital every 3 years does a community health needs assessment. And so this year happened to be that year. And so the number one thing that was found throughout focus groups throughout the state was that the primary—
Just for 2-minute warning, Dr. Smith.
Thank you, Kara. So what was the fact that behavioral and mental health was the number one thing identified in the state that could be the most useful to focus on over these next 3 to 4 years. Next slide. So we came up with something called the CHAMP model, which is really integrated behavioral health in primary care. And this is our overall structure where we would like to embed therapists and that type of thing, but then also encompasses the foundational project of the communication and collaboration with primary care physicians around the state, as well as the therapy consult with those primary care physicians. Next slide. So what we're going to be able to do with the award is to set up these educational sessions and teleconsultation, as well as with the expansion award, we're going to move into schools. Next slide. So this is our 4-year model. It starts with foundational work that we're doing now and ends with sustainability is where we would like to go. Next slide. This is the obligatory 4-year a timeline that we have. Next slide. And so this is the state, and this is kind of where people are located. So our expansion is going to look like this. Next slide. In year 1, we will focus on some owned practices so that we can figure out the best way to do that. In year 2, next. We will expand to other practices throughout our Arkansas Children's Care Network. Next slide. In year 3, we will add even more practices. And next slide, in year 4, we will saturate the state, including pediatricians and family medicine. Last slide. And so our expansion is going to allow us to also championing, I can't even say that word. We're gonna take CHAMP to our schools, and so this shows the things that we're going to be able to do this year with our expansion award. Next slide. These are our outcomes that we have identified in our grant. Short term, we just want to increase providers that are trained, and then long term, we would really love to impact service delivery models for mental and behavioral health treatment in Arkansas. Next slide. And that ends the presentation.
Great, thank you so much. Next up, we have the Illinois Department of Public Health. The project director is Kenya McCrae. Kenya, I'll turn it over to you.
Good afternoon, everyone. Nice to see you. You can hear me okay? Okay, very, very good. So I already introduced myself. They already introduced me. I'm Kenya McCrae. I am the project director for this. I am the division chief for the Maternal Child and Health and Family Services Division at the Illinois Department of Public Health, and I also serve as the Title V director. Next slide. So I'm just this is going to be real quick and easy. So I want to introduce you to our core team, and I know some of them are on the line with me, and when I call your name, you can just take your face out and just smile and everyone can see who you are. So just to let you know, I will start first with Lisa Macenter, our deputy director. I'm in the Office of Women's Health and Family Services, and so Dr. Macenter is going to be one of our IDPH content experts. Next, we have Julie Davis, who is our assistant deputy director, also with the Office of Women's Health, and she's going to be our other IDPH content expert. And you will probably, thank you. And you will probably see her quite a bit because she is going to be helping double down on the duties that I have. Next, I would like to introduce Julia Howland. She's our child and adolescent health epidemiologist. And for the project, she is going to be the data manager. So she's going to be working with some specific teams that we have, and I will explain that when I get to those individuals.
Nice to meet you, everyone.
Great. And we also have Kelly Vrablik. She is our child and adolescent health coordinator, and she's going to serve as the project manager for this grant. Didn't hear her, but she probably just, okay, great. And so you all also will be interacting with her quite a bit. We have Leandra Diaz. I don't know if Leandra made it on today, but she's our Title V admin assistant. And so she's going to be assisting as well, just to help keep us all in order and keep things moving. And then we have Evengia Samala. We call her Jenny. And so it's just easier for me to remember. And she is our fiscal manager at the Office of Women's Health. And so she's going to be fiscal manager on this particular project. And then we have key partners that are involved in the program with us. So we have Illinois Doc Assist, who they currently have a system that provides mental health consultations, and they do pediatric mental health consultations, and they also do maternal health consultations. And so we're trying to leverage that as part of our project. And so they're going to continue to provide those type of consultations, but we're going to really hope to help them expand, help them increase their workforce, and then expand throughout all of Illinois. Then we also have the University of Illinois College of Medicine, Academic Internal Medicine. That is who Julia will be partnering with specifically. They're going to help us get the database and collect all of the data that we need and make sure Illinois Doc Assist has a really robust data system to collect all the information so we can do analyses and also identify additional gaps and things of what needs to be done in the state.
You have 2 more minutes.
Great. Another key partner is the American Academy of Pediatrics, and they are the group that's going to help us get to our frontline providers, not just pediatricians, but emergency docs and nurse practitioners. They're also going to try to work with some of our school health centers and things of that sort. Next slide. And so just so you know, we are in Illinois, and this is a map of where we have child and adolescent health, child and adolescent psychiatrists shortages. The red means we need help. We need dire help. Yellow, we have some things there. Green, which we only have one of, means that there's sufficient individuals there. And the gray, we just don't have enough information. So we plan on reaching the whole state. Next click. There you go. And just so you can kind of see where Illinois Doc Assist currently reaches, the orange is the Chicago-Cook County area. And as you can see, that is where there's a lot of need. And so, and then you just see some of the other areas as well. We're in the southern part and in the upper northern part as well. But we want to just expand and really have touch the full state. Next slide. I know this slide is very, very busy, so I'm going to go really quickly on this. Our projects will include a need assessments for the first year and really talking to providers, talking to community, talking to key stakeholders, the other state agencies, and finding out what the need is and how we need to build on what Doc Assist currently does. We're going to create provider trainings, as I said before, staff development, especially within Doc Assist. We are going to create like toolkits for resources and referrals for the various provider buckets that we're going to be working with, and also including our presence on websites, so web development and outreach. And then you just see some of the outputs, trainings, more touch with the community and all of that. And our outcomes, we're committed to provide knowledge and increase resource options. We want to make sure in the midterm outcomes are increased Doc Assist services and specialty staff, and long-term to improve pediatric mental health in Illinois. And you can see how we're trying to get to all, we're going to evaluate all of our outcomes, our impact evaluation, process evaluation, and how we're going to collect information in some of our data sources. And last slide, that is me, and that is Kelly. That's our contact information. I made it.
Yes, you did. Thank you so much. Thank you. Our next awardee is My Health, My Resources of Tarrant County, Texas, and the project director is Todd Treat. Todd, I'll turn it over to you.
Hi, thanks, Kara. Appreciate that. Good afternoon. My name is Todd Treat. I am a senior director with Child and Family Services with My Health, My Resources in Fort Worth, Texas. We're very excited to have this, to work with this group and have this project to expand mental health care access in our county and hopefully throughout our state. As we've seen a continual increase, like all of you, in mental health needs for children and youth, we've also seen that decrease in the number of mental health professionals that can provide sustainable care to families and mental health with mental health conditions. 2.5 years ago, next slide. 2.5 years ago, we instituted a system called Help Me Grow for our 0 to 5 age population, which allows us to assess kids in the early age to assist with resource allocation based on the needs that are presented. Social determinants of health screen and other screeners are used to complete with families to connect them with the best resource in our community. Due to the success of that, we initiated an enhancement last February called Help Me Thrive, which then expands that to 6 to 17-year-olds. And again, it works with all families to find the best resources, not only in Tarrant County, but also in neighboring counties in our northern and central parts of the state. Next slide. Resources and programs are being developed on a continuum based on the needs of the family. As you can see, the continuum goes from promotion to crisis. And we're trying to figure out how do we find all services within any part of that continuum and where are the gaps in that continuum. And so the goal of our project is to look at those gaps, figure out where they are, and work with our providers in local primary health and also in school systems to address those gaps and meet those needs as best we can. Next slide. So as we enter this project, our goal is to work in conjunction with our community and state partners and key stakeholders in kind of 3 main areas. First, our goal is to assess the self-efficacy of primary care providers and school staff on mental health knowledge and competency. Following these assessments, we'll connect the providers to training to increase their knowledge and competency so they can provide holistic services when appropriate. We found that obviously with the shortage of mental health psychiatry and providers, the more we can kind of help equip primary care physicians and school officials with knowing how to deal with certain mental health conditions, mental health disorders, that might take some of the load off of the psychiatry and mental health community, and they can just help assist with collaborative care and integrated care models. Next slide. So the goal is as we expand provider capacity, then hopefully referrals for mental health specific service be reduced, which will again increase that capacity. Our goal is to embed mental health consultants and navigators into healthcare systems. The mental health professionals will be that linking point from primary care and to the psychiatric community. We have found that many in our community, in our area, are siloed, and we don't have a good system of collaboration or a system of working together or connecting those resources between there. We utilize the—
You have 2 more minutes.
All right, thanks. We utilize the assessments completed, again, to find early intervention with families so we can connect kids early and hopefully help with long-term outcomes. And also, as we develop this pilot, we're hoping to create kind of methods and models that can be replicated not only in our county, but across the state that are the best collaborative care as far as this integration and embedding of mental health professionals. Next slide. And then we'll also work with school systems in our county. Our goal is to have navigators in the school systems that can work with the school staff themselves and also develop WOW Talks and other types of parent cafes and resources for schools to again assist families and help them help the kids not miss school time as well as get that collaborative care model there. Next slide. This is the team that'll be helping to make that happen as we work with our community and our state key stakeholders to create these programs of collaboration and hopefully keep developing those models that can be duplicated as we try and create care that's not siloed, but is holistic for families in our area. Thank you very much.
Wonderful, thank you. Next up, we have the Federated States of Micronesia, and I actually don't see them on yet. Is there anyone else from the team aside from Sherlyn or Benito that we're planning to join? We can let them introduce themselves towards the end of the webinar if there's no one on the team on right now, and we can move to the Commonwealth of the Northern Mariana Islands, or CNMI. We have the project director, Joe Villagomez, on.
I'm sorry, I'm turning it on. I got
There we
locked
go.
out. I got locked out. Okay, so my name is Joe Kevin Villagomez from the Commonwealth of the Northern Mariana Islands. And I'm here to present our pediatric mental health care access grant. Next, please. So this is where we are, way over here on the other side of the international date line. It's Thursday morning. So good morning to all of you. Next slide. Okay, the head of our healthcare corporation is Dr. Esther Munia, and I'm the project director, and I also serve as the director for the Community Guidance Center, which is the main behavioral health provider, services provider here in the Commonwealth of the Northern Mariana Islands. And it comprises of 3 populated islands. I'm on the island of Saipan, which is the most populated, but there's the island of Tinian and Rhoda that we also have to do in our coverage. My key participants, Heather Pangilinan, Reina Soros, and Vina Azuzu, they're all on the call, but it's 4:36 in the morning, and I'm sure if I ask them to turn on their camera, I will never hear the end of it. So they're with me. We work together closely. Next. Next slide, please. Okay, so this is what we've done so far. We've already set the base grant and the supplemental award budget, EBH. We've met with our key key stakeholders, the pediatrician and the psychiatrists and ER docs. It's easy for us to communicate with this because we all belong to the same the corporation. So we set up a meeting, and then we started identifying who else we should be working with. So not only are we addressing the physicians that are working within the healthcare department, but also to work with some of the healthcare providers in the private sector. There's not a whole bunch, but still we need to reach out to them. We have initiated already, we've submitted everything to hire project coordinator to our HR office, and we told them the urgency of getting this up and running. And we also developed a organizational chart for our pediatric mental health care access. Next. And this is what our basic pediatric mental health care access looks like. With after the project coordinator, we have the physical, the data specialist and the data, and then we have the behavioral health navigators that will be out and about in the clinics and working with doctors, and then getting all the the referrals that needs to be done. We're also needing to expand our ability to get our telehealth ability up and running, especially for the pediatricians and the other healthcare providers to be able to access the behavioral health professionals that will be able to assist with the challenges. Next slide. We are now, these are ongoing tasks. We're securing an office space already. Actually, we already identified and working on that. We're identifying the key program staff. We've worked on the position description and minimum qualification needed, and working with our human resource to get them hired. Workforce, I know it's a challenge for everybody. It's especially a challenge out here in the islands because there's just not that many individuals with backgrounds in behavioral health. So we work closely with the college to try to identify people that are interested in entering. We are doing the process of the needs assessment, doing a procurement on our request for a proposal for that.
Joey, I'm sorry, you have 1 minute left.
Okay, and the advisory committee, we're putting it all together as we speak. Next. Yeah. Less than 1 minute. I'm done. Thank you.
Thank you so much, Joe. And thank you for joining us so very early in the morning. And again, hopefully our colleagues from the Federated States of Micronesia will be joining soon and can introduce themselves. But in the meantime, welcome again to our new awardees. And now to introduce the TA providers, I'll turn it over to fellow project officer Patrice Moss.
Alrighty, so good morning again to our Pacific Islander awardees that are on the call today, and then good afternoon to all of our other PMHCA awardees. I have the pleasure of introducing our technical assistance providers. Next slide. So we are going to start off with our TA Innovation Center. Our contractor is JBS International, and I will now turn it over to Teresa Lemus.
Well, good afternoon to everyone. Just making sure you can hear me. I see a nod. Okay, terrific. Well, I have the pleasure to spend just a few minutes talking about the TA Innovation Center. We are very excited. I am joined today on this webinar by two of my colleagues, Carrie Earle and Pam Baston, who are working with me to set up the TA Innovation Center to make sure that we are here to guide, help, and support you all as you carry out this very important work. We're very excited about it. So I'll just spend a few minutes talking a little bit about our TA strategy and then turn it over. So go ahead and go to the next slide. All right, so I'm first and foremost, what I would say about the technical assistance that we'll be providing through the TA Innovation Center is that we are extremely focused and very sensitive to the need of all of the awardees. And, we really only want to be value add. So we're very interested in understanding, how we will be value add to the work that you're doing to help assist. I love just hearing about the awardees, the new awardees, and some of the things that you're working on right now. And heard a little bit about just replicable models and things like that I think we are very interested in helping to support throughout this period. I'm just not going to read through this whole slide, but just say a few things that sort of, give you a sense of how we're guided in terms of our TA technical assistance. Obviously, to both sets of awardees, the PMHCA and the maternal depression and related behavioral disorders, to support both projects or both sides of those awardees. By facilitating technical assistance that is really defined by all of you. And so our goal is to really focus on helping you achieve your goals, looking at performance measurement, how to measure the quality and continuous work that you're doing, and then providing cutting edge subject matter expertise in the areas that you all identify are needed. And then really working with you to share information, sharing lessons learned, and some of those models that can be replicated across sites. Next slide. We have a few partners that are working with us on the development of the technical assistance that we'll be providing. One is the National Network of Child Psychiatry Access Programs. I think many of you may already have some contact points with them, and we're very excited to work with them to bring to you, again, expertise to help you carry out your work. We're also consulting with Dr. Nancy Byatt, who is with the University of Massachusetts and the founder of Lifeline for Moms. So we'll be working with her. And again, I know many of you might already have touch points, but again, to try to bring their expertise to bear so that you all can benefit from that, whether that be through general webinars or peer-to-peer sort of work or with site visits. And then we have one additional partner, Windrose Vision, who will be evaluating the technical assistance that we're providing. Next slide. This sort of just gives you a picture of how we're focused, and right in the smack dab middle is relationship based capacity building support. And I would say for our team, this is all about relationships and really having a good understanding, again, of the needs of the work that you're doing. So our relationships with you, our relationship with our partners, and then hopefully connecting relationships to, with each other across different sites. So
Our TA will be, our technical assistance, short TA for short, will really be based on a needs assessment that we are just now starting to kick off in terms of understanding, again, what are the biggest needs of the existing and new awardees? Where do you need help? Where are some areas that you have ideas and just need some support in bringing those to fruition? And so we'll be reaching out. We have some opportunities to hear from all of you specifically around what your needs are. And then those needs can be met through various ways. It will have different ways to provide technical assistance. It could be face-to-face through site visits. We certainly will be present at the awardee meeting in March. We are definitely planning to conduct peer-to-peer types of opportunities so that there can be sharing of information. And then we'll have dissemination of materials, again, from our partners and others in the field to help support the work that you're doing. Next slide. So we wanted to just leave you today with, well, again, to tell you how excited we are and to find out from you to get you guys used to all of our questions around, what are your needs? We have a polling question. If you have, sorry, I'm trying to see my question here. What is the most important technical assistance need that you currently have or anticipate having for the work that you're kicking off? And if you wouldn't mind putting your answer in the chat, then that can get us started in terms of understanding kind of where you're at. And we appreciate that. And next slide. And you can email us at MCHTA Innovation Center at jbsinternational.com. And we look forward to hearing from you, and we'll be certainly reaching out to you in the near future. Thank you.
Thank you, Teresa. I didn't have to give you a warning. Alrighty, so we are moving on to our next TA provider. And as Madhavi shared at the top of the call, the American Academy of Pediatrics has been brought on to provide support as a part of our expansion awards. And so I will now turn it over to Julie to run us through our slides.
Great, thanks Patrice, and thanks everybody for having us today. I'm joined by my colleague, Dr. Deborah Waldron, who's our Senior Vice President of Healthy, Resilient Children, Youth, and Families, and the Medical Director over this program. So as Patrice said, AAP has been contracted to provide TA directly to primary care providers to help them to provide mental health care in their practice, and then also to work with you all at the Pediatric Mental Health Care Access Programs to support that care. Next slide. This is our staff team. Next slide. So the American Academy of Pediatrics, just for those of you that may not be familiar with us, we're the national professional organization for pediatricians, and our mission is to work to obtain optimal physical, mental, and social health and well-being for all children from infancy through young adulthood. Next slide. The picture of our building in Itasca, Illinois. So AAP is a member organization. We have 67,000 member pediatricians. We have 66 chapters across the United States and Canada. Those chapters are, for the most part, organized at the state level. And so I know many of you all and the Mental Health Care Access Programs have good relationships with the state chapter in your state. The Academy really serves as a leader in the research and development of evidence-based policies to guide clinical practice. And so we are excited to kind of work with our networks of pediatricians to enhance capacity around mental health care through this program. Next slide. So the goal of our work as a TA provider is really to build capacity of pediatricians and of other pediatric primary care providers who are serving children to better support the mental and relational health needs of children, adolescents, and families. And in addition to that, and as a mechanism to do that, to really increase their ability to effectively connect with mental health care access programs. Next slide. So we've put together a couple of objectives to help us achieve this goal. So first, we want to figure out kind of where pediatricians and other primary care providers are at baseline. And so we're going to start by assessing the needs and competencies of primary care providers related to their current delivery of mental health services and relationships with pediatric mental health care access programs. We're then going to use the information from that needs assessment to develop and implement technical assistance activities. And those are going to be designed to support primary care providers in addressing the mental and relational health needs of their patients and families. We have a wide reach at the Academy as a national organization, so we'll be leveraging the networks of our AAP members, our chapters, and our partners to really support individual primary care providers and practices in accessing the access programs. And then we'll be developing and disseminating resources for primary care providers that highlight best practices and lessons learned, how you can really make the most out of your relationship with your pediatric mental health care access program. And of course, we'll be evaluating our project reach, impact, and outcomes. Next slide. And then these are just an example of some of the activities that we have planned for the next year. So we'll be forming a national advisory group to lead this work, and that advisory group will be made up of folks that have expertise in mental and behavioral health care, in primary care. We'll have youth and family representation on that group. In addition to that, we'll have partnerships with other national medical organizations who do provide health services to children and families. We'll have a slate of formative research to inform our technical assistance and our resources, and then we'll be putting out a broad variety of web-based technical assistance opportunities and resources, interactive learning opportunities. We'll be leveraging Project Echo for a QI learning collaborative. And then we're really excited to launch a communications campaign that will be directed at primary care providers about kind of what the pediatric mental health care programs are and how they can access and utilize them within their own states. We also will be putting out a cohort of small grants to AAP chapters and to the state chapters of other medical organizations. Those small grants will be designed to sort of help strengthen the relationship between the state chapter and the mental health care access program. And of course, we'll be collaborating with you all and with other HRSA grantees as we carry out this work. And of course, evaluation. So we'll be looking at the reach of this program and the impact of this program. And I think that brings it to the end of my time. Next slide. Yep, there's my contact information, and I can take any questions at the end.
Thanks, Julie. All righty. So we will move on to our next presentation. It'll be from the School-Based Health Alliance, and I believe Katie.
Yes, thanks.
Okay.
So hi, everyone. My name is Katie Stinchfield. I'm thrilled to be joining you today to introduce the School-Based Health Alliance and how we might support your efforts. Next slide. So some background information. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based healthcare. Since 1995, the School-Based Health Alliance, or SBHA, has supported and advocated for high-quality healthcare in schools for the nation's most vulnerable children. Working at the intersection of healthcare and education, SBHA is a recognized leader in the field and a source for information on best practices for philanthropic, federal, state, and local partners and policymakers. Our focus includes policy, standards, data, and training to support and grow school-based healthcare, particularly school-based health centers, or SBHCs. We believe that all children, next slide, thank you. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack equitable access to healthcare services. School-based healthcare is the solution, bringing healthcare to where students typically spend the majority of their time, in school. When health and education come together, great things happen. Attendance improves, conditions like asthma or diabetes are better managed, and behavioral health issues get quick expert attention. And we all know that healthy students make better learners. Next slide. So I want to introduce our team briefly. Again, my name is Katie Stinchfield, and I'll be the project director for this work. I'm also joined by Laura Hurwitz, who you'll hear from shortly, in addition to several other team members who will support us at SBHA. Next slide. So we'll share some infographics with you following this call, but wanted to give you some background about how schools can support student health and well-being. Comprehensive school health and wellness services are powerful tools for achieving health equity among children and adolescents, particularly those who unjustly experience disparities in outcomes because of their race, ethnicity, or family income. The goal is to create and uphold intersecting systems of care that support children in being healthy, feeling safe, and effectively engaging with school. Funding from these services can come from various community health and education funding sources, including Medicaid reimbursement. Schools can support student health through several models: school health services and school-based health care. The following descriptions are intended to provide a broad overview of these two models. So in practice, many schools implement both or variations of one or both of these, depending on the resources available. Next slide. School health services include, but are not limited to, school nursing, school counseling, school psychology, school social work services. The usual governing entity of school health services is the local education agency, and the legal authority governing health data and privacy is the Family Educational Rights and Privacy Act, or FERPA. Next slide. And school-based healthcare is provided through school and community health organization partnerships in collaboration with school administration and health services staff. So that could include, but is not limited to, primary care, mental health, oral health, and vision services. This care complements, but does not replace or duplicate, the existing school health services. The usual governing entity of school-based healthcare is the Community Healthcare Organization, and the legal authority governing data and privacy is the Health Insurance Portability and Accountability Act, or HIPAA. School-based health centers, the model that we promote, offers the most comprehensive type of school-based healthcare. The CDC Community Preventive Services Task Force recommends SPHCs as an evidence-based model that improves educational and health outcomes. And SPHCs provide the nation's vulnerable children and youth with access to fully integrated primary care, mental behavioral health, oral health, and vision care in an established health center setting where they spend the majority of their time at school. Working at the intersection of health and education, they collaborate with school districts, school principals, teachers, school staff, families, and students. And this type of collaboration and care coordination results in not only improved student, school staff, and community health literacy, but also contributes to positive educational outcomes like reduced absenteeism, decreased disciplinary actions and suspensions, and improved graduation rates. Next slide. So again, this will be included in the infographic we send you, but this is a comparison between the types of health services I was just talking about provided by the school or school-based healthcare. Next slide. And another resource we'll share, our field developed these 7 core competencies to achieve excellence in delivering care in a school setting. So again, that will be shared with you after our presentation. I'm going to pass to Laura now for a deeper dive on what we'll be doing with you. Thanks.
Next slide, please. Thank you, Katie, for giving us that background. So we thought that it was really important in embarking on this project to provide a snapshot of where PMHCAs are located in the state and where our state level school health center entities are, which include the state, the SBHA, School-Based Health Alliance, state affiliates, as well as school-based health center state program offices. So this, we can see some overlaps here. This is another resource we'll be sharing with you. And we do see as one of our key roles in this project, helping to make these connections between these entities at the state level. Next slide, please. And here's a description of each entity. Again, we've got our own organization, the state program offices, state affiliates, and of course, the Pediatric Mental Health Care Access Network. I should say the School-Based Health Alliance, in addition to these connections, has multiple and maintains multiple connections also with individual school health centers and sponsoring organizations across the country. Next slide, please. So it was enlightening to hear some of the other TA providers speak about their approaches, because we are very much taking a similar approach to providing our technical assistance. We do want to spend the first phase of our work in getting to know all of the awardees and their needs. So we will be information sharing with you like we are today. We will also be providing opportunities for network, facilitating network, offering some informal TA sessions through virtual office hours. And as we get to know your needs more specifically, we will be developing tools and resources. We suspect that these resources and tools will be around issues of providing consultation in the school setting, whether it be a school health center or a school itself. But we will wait and see what everyone's needs are before deciding exactly what those resources will look like. We also will be providing communications, campaigns, and marketing to make sure that our schools and school health centers know about the PMHCAs and other national partners that our organization has. In addition, we will provide some web-based training, again, once we know the needs, to our awardees, to other awardees, whether it be webinars or a learning collaborative. We're not sure of the exact structure, but we're excited to create that and see how that evolves over the year. We will see, as I mentioned, one of our roles as really facilitating partnerships throughout the year, and we're excited about seeing where those take place and how they evolve. And finally, we suspect some of you are already doing work in schools, and there will be some exciting things happening, and we really would like to highlight the exemplary practices of PMHCAs that have made it into the school setting, have done some learning, and we would like to elevate and highlight that through some case studies. So like everyone, we're looking forward to finding out about everyone's needs and working with all of you to collaboratively support PMHCAs during this year. And the final slide, thank you, are just some ways that you can connect with us. Our biweekly e-newsletter is a place to get some more detailed information. And then we've got our social media outlets here. We will be following up, as Katie mentioned, and as I mentioned, with some materials that we weren't able to go into detail. So thank you so much.
All righty, thank you, Katie and Laura. So we have one more TA provider that will be providing a presentation today, but we are actually going to pause now to see if there are any questions for the TA Center, for the School-Based Health Alliance, or for the AAP. If you'd like to drop your questions in the chat, feel free. If you'd like to come off mute, we welcome you. Okay, well, seeing no questions and hearing no one, we are actually going to take a short break, a 5-minute break right now. So you all are welcome to get up and stretch your legs. And then when we come back, hopefully we'll be able to do our final TA provider presentation. If not, we'll continue with the presentation and circle back to the last TA presentation. So 5-minute break. See you all back in a few.
Okay, I'll pull up the slides if you want to start chatting.
All righty, so we will get started with our next session. It's been referenced a few times today already, but many of you do know that we have a sister program, the Maternal Depression and Related Behavioral Disorders, or MDRBD, which does not roll off the tongue as smoothly as PMHCA. I guess they're equally as tough to roll off the tongue. But the MDRBD program sits in MCH's Division of Healthy Start and Perinatal Services. And so we have several programs who several states who share both programs. And so the MCHB Associate Administrator, Dr. Warren, has actually expressed interest in learning how states with both programs are collaborating and addressing perinatal and postpartum behavioral health concerns in their states. And so today we have the pleasure of hearing from the folks in Rhode Island. We'll be hearing from Sarah Hagan from the Pediatric Psychiatry Resource Network. And we'll also be hearing from Jim Beasley, Kristen, and I believe Blythe may be on the line as well from the Rhode Island Maternal Psychiatry Resource Network. So I will turn it over to you guys. Thanks.
Thank you, Kelly. This is Blythe Berger. I'm just going to introduce Jim and Sarah, who are going to be talking about our collaboration between our maternal and child health mental access programs. In Rhode Island, we call these MOMS PRN and PDPRN, which stands for Psychiatry Resource Network. So Dr. Hagan is the program manager for PDPRN. She's a pediatric psychologist in the Division of Child and Adolescent Psychiatry at the Rhode Island and Hasbro Children's Hospitals, and is also an assistant professor in the Department of Psychiatry and Human Behavior at Brown University Medical School. Jim Beasley is the program manager for MOMS PRN. And before this, he worked in the oral health program at the department, and he also has extensive experience in child advocacy. And these two individuals are really key to this successful collaboration. So I'm excited that everyone gets to hear from them. And so with that, I'm going to turn it over to Jim and Sarah. Thank you.
Awesome, thank you so much. And you can go to the next slide, please. So yes, it's a pleasure to speak with everyone about collaborations, about how access lines can certainly work together to sort of accelerate impact and improve behavioral health outcomes. Just to provide some context, in Rhode Island, as Blythe was mentioning before, we do have two statewide programs that do operate independently, and that's because they, our clinical services are provided by two different hospital systems. Our MOMS PRN program is the perinatal MDR-RBD program, and we have partnered up with the Center for Women's Behavioral Health at Women and Infants Hospital. So just to give you a sense, like 80% of all of our births occur at that hospital, and they're certainly national experts. They certainly established early on for the past 20 years, like a partial hospitalization program. So they're certainly where the clinical experts when sort of RIDO got awarded this grant to partner up with, and they certainly provide all the teleconsultation services specific to perinatal patients. And then Dr. Hagan can talk about Bradley Hospital a little bit.
Yeah, thanks. So Bradley Hospital, I'm always proud to say, is the nation's first psychiatric hospital for children. And so we're also a part of a larger hospital system. So as Blythe was mentioning, like all these different hospitals, they're all a part of the Lifespan system, which is unfortunately not a part of the Women and Infants Hospital, which is amazing, where our Rhode Island moms are located, or the sister program. So Bradley continues to be a wonderful psychiatric hospital devoted to helping children and families throughout the state of Rhode Island, and actually beyond at this point. And we're very grateful to have this coordinated effort with Rhode Island moms, who, as Jim was saying, is the expert here in terms of in Rhode Island. So go ahead, Jim, keep going.
No, thank you. Again, so we operate independently just by clinical design, like there was no real choice, but certainly we've leveraged each other's relationships to further optimize both programs. And a key component has been because the Department of Health, for which myself and Blythe work for, we're the sole public health authority in the state. So we don't have any sort of county level sort of sister agencies. And the fact that we got awarded both of these fundings, that we played a key role in, I think, further collaborating both of these and aligning these efforts. And just to provide people with clinical context, in Rhode Island, there's about 15,000 perinatal individuals and around 209,000 kiddos. That's sort of our domain of impact. And we're a state of 1 million. So for many of you, it's probably like similar to a county, but we just wanted to give you a sense when it comes to any numbers that you have about sort of our reach and scope. So next slide, please. And a brief history too about how these programs have developed. We were lucky enough where we had some earlier momentum with PDPRN. The City of Rhode Island was awarded a State Innovation Model grant. It was a much broader triple aim alignment work grant that was awarded, but a key component of this was launching the PDPRN program. I think that sets up very, very nicely to receive the HRSA funding, not just for the PDPRN, but also be one of the 7 HRSA funded perinatal grantees. And so we're able to leverage a lot of infrastructure and learning as we go forward. And the good thing about both of these programs is, just like many of you are working hard across the country with your child access lines, is we have very similar program components. Both of these programs offer real-time telephone and consultation and resource referral supports, lots of professional education, but they also differ a little bit when it comes to in-depth and long-term provider supports, where we'll hear about in a little bit at our next slide. But so there are differences in sort of approaches, and some of that it has been by design of what are the grant deliverables, especially on the perinatal ones, about the types of data that you have to collect, but also our historical of what has worked really well for the PDPRN program since its launch in 2016. So you can go to the next slide, please. And so the service delivery, as I was saying, has been completely aligned in that they both provide same-day clinical assistance. These are statewide programs. We are small but mighty, so we're able to sort of focus on the entire state. Providers can call regardless of a patient's insurance type, carrier, or status. So that's been the real value add of being a HRSA funded program. And both programs have wonderful collaborative protocols identified, especially where there might be some overlap in who would be best positioned to address sort of the patient, especially when it comes to youth who are pregnant or postpartum. And they've had wonderful clinical discussions about how best to triage those folks, especially those under age 15 and under versus those 16 and above. And that really speaks to the licensing technicalities of both our clinicians at Women and Infants or Bradley Hospital. That being said, these programs are slightly nuanced and differ, at least on the mom side. We don't have any formal enrollment process. That was just given just our audience types of OB providers explicitly, they're very busy and we didn't want to get any cumbersome work when it comes to formally enrolling. And there's certainly pros and cons to that approach. We've also we have a slightly different scope of who we field phone calls from. So this is in large recognition to not every, especially with postpartum visits, those perinatal individuals may present not really at the OB. They may be more likely to be at a well child visit or a family home visitor. So early on, there was a strategic decision to open up the resource and referral support of the teleconsultation line to non-prescriber callers across the state. And again, that was just in recognition where, especially with postpartum visits, Medicaid coverage sort of not continuing until, limited postpartum, that there was a recognition to better try to align, I think, opportunities to better connect patients in care, especially given all the wonderful screening work that family home visitors and others are currently doing. And certainly with the quality improvement support too, this is really driven by grants, the grant deliverables on the MDRBD side of HRSA. So we have to sort of get screening data from practices explicitly about, deduplicated how many patients were screened for depression, anxiety, and substance use disorders. So we have learning collaborative cohorts that span 15 months so that we can team up, optimize those protocols, and get that EMR level data, which I think is just a different grant requirement than the PDPRN program. So on the mom side, there's less administrative barriers, but I think we more intensely work over a longer period of time with smaller groups of practices. And then Dr. Hagan, I don't know if you want to just provide a quick overview of PDPRN.
Yeah, I think you highlighted some of them, but I'll just mention that we do have a more formal enrollment process. Some of that is pre-existing from some reporting from our funding from SIN in the past. We've also found it really helpful in terms of being able to help with tracking throughout the state and any changes in practices. and just in general, kind of obtaining information and disseminating information to practices who enroll. We will take calls from folks who haven't enrolled as well, and then just encourage them to enroll. And then from the perspective of who we're getting our calls from, we do try to limit it to our pediatric community-based providers. So that's pediatricians and anyone in family medicine, and any kind of pediatric primary care provider, really. And some of the behavioral health providers and social workers within their practices will call as well for support. We have gotten calls from other, programs, and we'll take those calls, but we're not advertising to them, and we're not, looking to kind of enroll them in our program at this time. We're very fortunate that there's a lot of other services in Rhode Island that cover some of these. And then we do offer this peer learning training in terms of having opportunities for pediatric primary care providers to participate in almost monthly. It's like 10 sessions a year on different topics, and get kind of more intensive training on anxiety, depression, other mental health topics that they're dealing with in their practices, and in terms of how to do that. And the nice part about that is kind of, growing a group for that. And then, the quality improvement stuff, again, I'll say, like, I love that Rhode Island, that Moms is doing that. But we have other providers we have other collaboratives in our state that are really focusing on that. So we've just developed some partnerships with them in terms of coordinating services, which has been really lovely. And that's still some more shared opportunities for Rhode Island moms and PDPRN to share relationships with other programs in the state.
Yeah, thank you so much. And if you go to the next slide, we'll walk you quickly through some basic information that, when you go into context of what the scope of the services are, sort of who they're providing to, and sort of how they're supporting, you can really see the differences in the data, and it's all by design. So, not surprising, in PDPRN, a majority of their calls come from pediatricians. And on the mom side, you see a little more diverse mix, where we certainly have quite a bit of prenatal care providers, but that para support, the family visitors, the doulas are a larger portion of that. So you have different providers calling. And if you go to the next slide, you can see that these different providers have different sort of service needs. So on the mom side, they're really looking for outpatient treatments or the community-based sort of supports. Obviously, some needs formal evaluation or medication teleconsultations. And then on the PDPRN side, since they are really engaging with the lion's share of the pediatricians in the state of Rhode Island, they're really having more call volume when it comes to medication consultation, a little less about sort of resource and referral access compared to sort of what the moms want. So again, the way you design these programs, you'll see different reasons and call supports. And then if you go to another slide, you can also see that the things that they're addressing are slightly different too. So on the moms one, we're seeing a lot of like depression, anxiety, and PTSD, a little bit about substance use disorder. And again, on the PDPRN side, because they've been around a while as well, you're seeing some anxiety, obsessive compulsive disorder, ADHD, and then more of like the mental health ones as well. And I think that's a big difference that you'll see between both programs is when you're newer, you might just get what people, associate you with. And then as you go through the years, I think your cases get a little more complex, but they're completely different, clinical populations. So these, differences are certainly dense when it comes to the programs. And then if you go to our next slide, but a key area, I think, of how we've made this a success, and sort of we learned a lot from the PDPRN program, which has had a lot of great momentum since 2016, was that RIDA was that one entity that did get awarded both of these grants. And so there's been, and it's always by design, in 2018, when we did get these two grants, that our leadership, Blythe and others at the department really decided to focus on how we can intentionally collaborate and coordinate and align all of the activities. Even though there are different programs, different hospital systems, there's ways that we can leverage learning internally. One of the big ones was with staffing. So by design, with the grant applications, half of the program evaluator for the moms program was also going to serve as a half-time program manager for the PDPRN program. That was critical and early on, especially sort of learning a lot of different services and supports and sort of data collection and protocols and all the technocratic questions that I'm sure new grantees have about just launching a line. And so we're able to get a lot of information from there. And certainly when it comes to strategy development, how to sustain these programs, how to like promote them holistically, uniformly, how to sort of address emergent best practices, our MCH leadership and staff regularly meet to sort of ensure that that occurs. We've, budgeting that has over the years certainly has gotten a little bit more aligned and sort of collaborative. So especially with communication budgeting, so both programs jointly issue sort of purchase orders and work with vendors and with communication staff at RIDO and also that are external to the agency to really create wonderful joint marketing materials and reports and websites and all of that. So we're able to leverage each other's funds to sort of maximize what those collaborative efforts are. Branding, obviously, we followed the PDPRN, they were around, so it made complete sense to call ourselves the Rhode Island Moms PRN program. And certainly with outreach, there's been wonderful joint promotional efforts that have happened and occurred that have been organized, and because it just makes sense, I think, to holistically promote both services, even though they're from two different hospitals. And you're also seeing some snapshots below on this slide of just sort of our marketing materials, our program briefs that we've always done jointly, and a lot of great work on the RIDO website and others. So if you go to the next slide, please. And so when we talk about the growing clinical collaborations, a lot of the work, especially because of all the great work that was done just by the RIDO staffing and our MCH leadership, is that we were, again, really able to better align and coordinate, I think, our communication efforts, and especially with our data collection ones. One of them being sort of like the call encounter form that the Moms PRN program used. Was based on the PDPRN one, so we didn't have to start from scratch. And obviously we crosswalked that with our HRSA requirements, certainly because RIDO helped develop these joint promotional flyers, staff independently from each program when they're out and about giving sort of outreach or site visits, or professional education centers are able to holistically promote both lines, which is wonderful. And then with the reporting outcomes, we were well positioned to sort of identify which metrics that we'd publicly report jointly, which ones that we would sort of do at the program level, and didn't make any sense to sort of combine. And so thinking through how we publicly report, what we jointly report, and then also try to, from a stylistic standpoint, also create case examples that help explain what these services are. We often find that visuals help. So again, with that joint communication budget, we're able to do sort of, stylistically aligned sort of deliverables when it came from our case examples or infographics or those joint policy briefs, which has been wonderful, which again, you're seeing sort of highlighted with some of these slides in the middle context about how we can make them similar but different. And so hopefully it's landing when providers see all this information or various stakeholders, they get that they are connected in really two statewide programs that have different levels of support. And then I'll pause there for Dr. Hagan about the clinical coordination as well.
Yeah, thank you, Jim. It's been interesting to see our growth as two teams coming together throughout this process. We've actually had to tackle some important hurdles together. I think Jim is going to speak about some of those regarding like sustainability efforts, which has really brought us together as a team. I really look forward to our monthly meetings and collaborating with the Rhode Island Moms team, sharing ideas and developing strategies. And we've started coordinating efforts with our advisory meetings as well. PDPRN has had standing advisory meetings for a while. As Jim said, we've been just existing for longer, but it's been wonderful to include moms, PRN staff in those meetings to get their feedback, but to also just kind of share the meeting in terms of getting information and support from different coalitions and community providers who are on our advisory meeting and on our advisory team in terms of helping us move forward with our next steps in any kind of program development. So I'd say over the past year or so, as we've been doing this, it's just gotten richer and richer, which is lovely, in terms of feeling like we have a team moving forward, coming from two different places.
Yeah, thank you so much. And then if you go to our next slide, please. And having that infrastructure where not only sort of the RIDO MCH leadership, but then the programs themselves collaborate, and then we've got the broader engagement with the sort of the advisory committee that PDPRN hosts and that the Moms PRN program is a formal member of and continually things, that really helped us leverage and really think through a much more integrated sustainability plan that we are sort of enacting currently. So all of the PRN partners, whether it be RIDO, our clinical partners at Women Infants or Bradley Hospital, we're really thinking holistically when it comes to how we can sort of sustain these programs. Obviously, one of the strategies will be sort of any HRSA call for funding notices that get released, but more locally, we've also sort of been advancing a unified legislative proposal that would sort of seek to sustain these services through a health plan assessment. And so, developing sort of, plan, budgeting, identifying legislative texts, and certainly is collaboratively engaging stakeholders for support with our local General Assembly has been a key activity that has been highly coordinated and highly integrated. So when we're talking to our local AAP chapters, the Medical Society, other child advocacy organizations or coalitions across the state, our mental health sort of groups or affinity partners, all of that outreach and coordination and engagement has always been joint, which has been wonderful. And because of that, we have a unified, legislative approach that has a unified budget if it ever does pass the General Assembly, will sustain these programs jointly, which has been wonderful. And so in Rhode Island, we have 6-month General Assembly sessions where they meet 3 days a week at night. We had some wonderful momentum that all of the program partners were able to achieve. And so that screenshot that you're seeing is actually the sort of journal count, the journal of the Senate when the funding bill passed the entire Senate unanimously, which was wonderful. In the House, we ran out of time and it sort of needed some more efforts and time with that. So we're looking forward to sort of jointly preparing for the 2023 session. And so we're getting all of our ducks in a row and certainly investigating other sustainability options. And again, and that's all through that joint infrastructure that we have with not only at RIDO, but with our clinical partners in all these meetings about how best to land the plane to ensure that funding is sustained if we're not successful with any sort of HRSA continuation applications. And so it's been a key component, I think, really thinking this through, and there's been a lot of wonderful leveraging. So certainly as you're thinking of not only expanding or partnering with perinatal programs, we definitely encourage you to think jointly about this because, framing it as a wonderful statewide programs that support 2 different populations, I think does increase the value add or interest in the proposals. And that's why we've seen some wonderful legislative support, at least locally as well. So you can go to the next slide as well. And certainly a big component too, aside from like sustainability planning and promotion and material development, has been sort of evaluation coordination. So as discussed previously, we certainly had a lot of discussions about which metrics when we're sort of trying to explain these programs and our outcomes to lay providers or stakeholders or the General Assembly of the state of Rhode Island in general, where we've done great work about defining variables and aligning them and getting communication toolkits in place that sort of help distill in a very top line level the impacts and outcomes we've achieved. There's been a lot of collaboration when it comes to other evaluation efforts. And again, this is another area where I think highly suggests if you're fortunate to have, 2 different access lines to collaborate with. One of the big ones is we're, especially with the all-payer claims database, both programs are pursuing analysis of them to better understand sort of behavioral health prevalence statewide, but also sort of what are we seeing as a result of impacts of these program services to date. Obviously, PDPRN, since they started earlier, they have a much more robust data set to review and sort of more defined outcomes potentially to seize. And where the mom side, we're just at the very beginning of this process. We're trying to better understand a perinatal data set and get a sense of what the behavioral health prevalence is across the state. And we've teamed up with Brown University to sort of help us with that. And the good thing about having both of the programs sort of, pursuing these all-payer claims database analysis is that they're able to debrief each other, coordinate, share best practices. So it's been wonderful to work with Dr. Haken and her team and have them formally and continuously debrief the Brown University research team about how best to proceed with enacting all of these studies. And again, having that aligned leadership within the Rhode Island Department of Health through Blythe and others is a great way to get approvals for all these studies as well. So, that's another way that we've been collaborating. And another way that we've been certainly have been doing this is also trying to leverage sort of instruments or data collection activities that the Department of Health is locally sort of legislatively mandated to do. One of them certainly has been our statewide health inventory sort of utilization and capacity surveys. So both—
Sorry, Jim, this is
Yep.
your 2-minute warning.
Oh, not a problem. So we're in Rhode Island, we have legislatively mandated provider surveys. And so both clinical staffs, and they go out to all different provider types, including psychiatrists and others. And so what we've been able to do is, because RIDO, again, is engaged on these projects, as our clinical partners have come forth to us and sort of provided edits and modifications to the psychiatry surveys that sort of are legislatively mandated to go out every couple of years. And I think that will better help us position to see and better understand what the psychiatry gaps are in the self-efficacy and comfort of addressing a perinatal and pediatric population. So again, that's another area where if you are fortunate to team up with a local Department of Health or a public health agency, to certainly come at them sort of uniformly to not only improve data collection so you can better understand what's happening in sort of provider capacity, but also to inform your outreach and efforts as well. So in the state of Rhode Island, we're fortunate to have a licensing database and also a children's health information system called KidsNet. And so again, we jointly request information to say, like, who are the pediatricians, who are the prenatal care providers, sort of what pediatricians have kids under 1, what have a higher proportion of Medicaid funding or Medicaid attributed kids. And so we can better target, I think, our outreach and engagement efforts to make sure that these programs are really serving a need in addressing health equity in general. And if you go to the next slide, please. That being said, so obviously we've done a lot of coordination when it comes to the state agency sort of staffing, obviously communication, evaluation, sustainability planning. There are challenges that come with collaborations, certainly, and these are just some food for thought, and happy to discuss anything further or get reactions from others. But, obviously the COVID-19 pandemic has greatly impacted, I think, the pacing or level of collaboration that we'd like to have seen occur. And it certainly has sort of addressed, I think stalled some aspects of it that we're now accelerating and sort of gaining momentum on. But there certainly are challenges and areas for improvement. I know just on sort of, our side, there's certainly, or, one of them has been sort of the unique and evolving provider needs, which can be sort of a difficulty. What sort of meets the pediatrician and how they've been supported by healthcare reform efforts in our state is a little different than where our OBs are. So the programs can't be fully aligned. So there are going to be inherent difficulties when you try to merge both types of programs. And certainly an area of improvement that we'd love to sort of work on has been our coordinated sort of directory optimizations. Both clinical services do a great job of vetting or getting a sense of, what's out there from the community-based supports and services to sort of refer or connect patients to care. But I think more integrated approach, I think, is one thing that we're definitely honing in on. And I'll let sort of Dr. Hagan as well speak to any difficulties or areas of improvement that could be occurring.
Yeah, I think we're working on, I think one of the main things to think about is when your programs come from different hospital systems. That's something that's been a challenge we've had to learn to overcome. Some of it is just even like not really knowing the other team as well, right? Like not having other opportunities in other meetings where you're sitting with them because they're in a different system and not knowing how their system functions in the same way. So we've learned a lot from each other in terms of how our systems function the same and different. They're both very large hospital systems and very important in the state of Rhode Island. And I think we've, had to come to learn to accept some of the differences. And then from a clinical perspective and with support from our RIDO members, who help kind of coordinate us all together and keep us aligned, we've been able to really kind of at least clinically make our own decisions and sort of, solidify sort of what we want to do for our program, independent of the systems we're coming from, to help ourselves move forward within those systems. And then I know there's some questions too, so I'm answering the chat, but that's one of the main clinical challenges we had to overcome was we're coming from two different places.
Yeah, thank you so much. We wanted to make sure that we had time for questions. I think I did see one question in the chat. And then if anyone else wants to come off mute and has a question for Sarah or Jim, please do so.
Yeah, so Katie, thanks. I was starting to type to you, but I'll respond. We are set up a little differently. Rhode Island Moms, and Jim, correct me if I'm wrong, but I think I know this now because we've been working together so much. Rhode Island Moms is staffed, their phone line is staffed by a social worker. She answers all the calls and she helps triage. Which I think is really important, given that a lot of the requests are for, treatment ideas and referrals. Our program is a little different in the sense that our calls are triaged through an administrative team. There are psychologists like myself and social workers and licensed mental health care providers who take those calls, those consult calls, but we're not necessarily the first person that the provider is talking to. So there is a slightly different triage system. What other questions do people have?
Yeah, and certainly as people are thinking questions, there's wonderful areas to sort of collaborate when it comes to staffing, budgeting, outreach, evaluation. But it's always good, I think, intentionally with the funding in Rhode Island, a key component of that success has been RIDO sort of helping be that sort of backbone, sort of glue to sort of bring them together and align them and sort of optimize the service delivery where most appropriate.
I'm such a clinician because all I keep thinking about is how trust. So I'll say, we're coming from two different systems. We don't really know each other well. We trust our RIDO partners. And so that really has disseminated into us building something together. And now that we've known each other better, there's a lot more trust within the two teams in terms of that. But I just want to reiterate what you said, Jim, because it is so important. We both came from a place of, we trust our teammates and in terms of our RIDO partners. And if they're saying we should kind of pull our resources and work together, then we're going to try it. And then the experience has just been really positive, which is nice. Not perfect, but positive.
Great. Well, thank you guys so much for sharing your experiences. I believe the next slide probably has you all's contact information, and we'll be sure to share that out with the rest of the group. And again, if folks have other questions, feel free to drop them in the chat. Wanted to just verbally see if there was anyone from EMSC on the line. I'm not seeing anyone. If not, we will move to the next presentation. So I'll turn it over to you, Jordy.
Thanks so much, Kelly. And thanks so much to the Rhode Island team for a great presentation and for your questions. As Madhavi shared in the beginning, we'll have further opportunity to dive into this topic on the 16th when JBS does a webinar on a similar thing. So we will now transition into a session on some policy and partnership wins, and we'll be hearing from Mississippi, Montana, and Georgia. And I will turn it over to Big Champ, the Mississippi program, if you are available.
Hi there. Hi, this is Gigi. Hopefully, can you all hear me?
Yes.
Okay, making sure. All right. Okay. And thank you, Jordy, for that, because you kind of took that phrase right out of my mouth. I was sitting here thinking like, what would that make us listening to the Arkansas team earlier? I was like, does that make us Mama Champ or Big Brother Champ or Big Champ, whichever. So we'll have to see kind of what rolls off the tongue. But and shout out to Chris Smith again, just for recognizing, saying like, well, calling themselves Baby Champ. Thought that was very sweet for them to put that out there. But they got a great name, and we're glad to have them on board. It's awesome to have another champ program in the mix. Good evening, everyone, or good morning, wherever you're located. My name is Gigi Holder. I am the program director for the CHAMP program, the Mississippi CHAMP program, which is the Child Access to Mental Health and Psychiatry, based out of the University of Mississippi Medical Center here in Jackson, where I'm located. And just today, just want to be able to talk about just again, like some partnerships that we've been able to culminate together in order to start moving towards other initiatives for our program, which involves like CHAMP for Schools, and then another grant project that we were able to come together and at least submit for that awarding. We don't know if we've gotten it yet, but it truly was a task and a big feat to put that together. And it really was an opportunity to bring so many different entities to the table. It was a tough experience, but an enjoyable one at the same time, because we had a lot of great conversations around that. So I'll start the conversation, and I know I'll be joined by our project manager, Mr. Terrence Hibbert, later on in the presentation. So next slide, please. All right, so just to kind of give a bit of a glimpse regarding our expansion here. And again, I'll probably just, so we won't get a little confused, I might say, you know, Mississippi CHAMP, you know, from time to time. But so for Mississippi CHAMP, you can see just kind of on the side here where we have listed in regarding our program expansion and how that's being fueled by the different entities, different agencies that we have brought to the table. Again, so we have our Department of Mental Health, and that is our sponsoring organization, which through the grant comes through, the PMHCA grant comes through. Again, we are here housed in the University of Mississippi Medical Center, so that puts us in a fortunate place and position where you know, other grants, you know, there's always someone working on something, is what we say. So other grants, you know, are kind of floating around out there. So we're able to contact and get in touch with other individuals. That's kind of how that's how we were able to get involved with our K-ECHO, which I'll talk about here in just a bit. But that's another opportunity and other partners that we were able to get in touch with, even though we're housed right here in the same clinic or in the same agency. The various community mental health centers that we have across the state, there are 13 regions across the state, and therefore each one having their own CMHC. And again, these are operated by the Department of Mental Health, so they oversee a lot of their work. So by having Department of Mental Health, then we have the access and be able to partner with the CMHCs in that case as well. Our State Department of Education, Mississippi Department of Education, Mississippi Achievement School Districts, and I'll talk about that a little bit more specifically. And then Families as Allies, they are our partnering organization directly written into the initial phase of this grant that we have now. And they are a statewide organization that is focused on a family-driven practice and family-driven support. And so just with this kind of diagram right here, you can kind of see it's kind of split into, like, the top half is more so our push or expansion into schools. And then at the bottom part, looking at what we're doing or what we're looking at doing regarding PCP offices. And of course, that's where our main consultation line is primarily focused on. So you can kind of see just with the legend right there that we're already doing like our main consultation line, that we have that going both with PCP offices and then with CHAMP for Schools as well. And then you can see with the green right there in the box to the top right is the CMHC ECHO project. This is truly one of our first expansions right here, and being able to introduce CHAMP for Schools as well. So with this, we are working with our Region 1 CMHC, which is in the northwest corner of the state, and located in one of the poorest regions as well, known as the Mississippi Delta. And so this was identified by our DMH to be able to connect with this organization with their school-based clinicians there at that site. And then some that work in inpatient facilities as well. So for us to be able to connect with them and offer our ECHO services, and they really have taken to that, that definitely has been a big success for us in that. And we are looking to expand that into other regions as well across the state. We've been able to do care training. So that is more specifically looking at positive behavioral interventions, kind of more of like a digestible format of it, as opposed to more in depth parent management trainings that we might do. So that's one that we've been able to do in other settings as well with other CMHCs throughout the region. So again, just kind of highlighting that. And then I'll just say too that our Department of Education also highlighted that they're interested in doing for us to be able to assist with a toolkit that they would like for their school-based staff to be able to, and teachers to be able to access as well. And that came from specifically having a meeting with them being able to say, like, teachers don't want any more like just videos or anything like that. Yeah, they do want to be able something that they can reach for and whatnot, but what about some live workshops? Is there anything that we're able to kind of tailor to, because everybody's needs are different, right down to internet connection throughout the state is different, you know? So what if they can't access that toolkit? There is a lot of different things that came from that. So there are different ideas that have been highlighted from our partners of how we can just start to expand into schools. And I will just say on this slide too, again, that how we mentioned about K-ECHO. So again, the clinic that we are housed in, which is the Center for Advancement of Youth, that we've been able to broaden our initial ECHO, which was just with our main CHAMP team and out of the Department of Psychiatry. And now we've been able to expand that to the pediatrics department here and those specialists in that area. And so that's that combination of those specialists in those areas when it comes to our K-ECHO series. That one has been our longest going ECHO series that has been going on for about a year now, and we are looking to continue with that collaboration of those specialists here in psychiatry and in pediatrics. I'll go ahead and go to the next slide, please. So our push into schools, again, it has been, that idea and that hope and that goal for quite a while now, but really being able to, again, look at who we needed to approach in order to start going down that pathway. And so it really came from having communications with our Department of Mental Health. Their Director of Child and Youth Services. She is on our advisory council and our sustainability council, very, very involved in CHAMP and the CHAMP program. And the CHAMP model is what we call it, the PMHCA model. So she's very invested in that. And so with having conversations with her, being able to recognize that that school-based employees in CMHCs have been seeing and are continuing to see an increase in complexity with children that they work with. Another thing that came from those talks is that in a variety of cases where employees do not feel as equipped to tend to these concerns that are coming up, with children and seeing this increase of cases. So again, just highlighting those talks that have been happening, and then just stemming into conversations with our Department of Education, and them recognizing between school counselors and then teaching staff with them seeing an increase in student behaviors, and those really being it's promoting that barrier. It promotes that barrier when it comes to kids being able to just learn in the learning environment anyway, which leads to, if kids are getting expelled, failing grades, so on and so forth. So it's just kind of like this domino effect of what they were seeing more so, not to say that it wasn't there before, but now I'm sure that we all know that with COVID having exacerbated things, kids were 1 minute they were in school and then disrupted, they were out of school and then getting back in. There's just been a lot to work with there. So our MDE, Department of Education, has really seen a need for even more training and support to be given to school-based staff to better address these concerns. And so from that, those conversations with these two agencies, it really allowed us to start looking at how can we start building a coalition that's ready to, kind of step up and take advantage of, if it's grant opportunities that are out there to allow us to do this work. And so there was one specifically that did come up that we were actually able to come together, a big group of us, and be able to put that work forward. Next slide, please.
Just 2-minute warning and then I'll.
Oh, okay. All right, so I'll just say really quickly, again, grant opportunities as an introduction, just from last year. Uh-oh, it advanced. Oh, it's got to keep going. There there we go. All right, thanks. We'll pause for reaction with that. Thank you. So just to say on this slide that, just kind of outlining that timeline of grants that either were proposed to us, that were shared with us, opportunities that came up. There was one particular grant that came out, the AWARE grant, that we had approached our MDE about, Department of Education, but at the time they weren't really ready or poised to take the lead on that. We were really hoping for that. But then there was another opportunity that came up for Project AWARE, that grant, where again, they weren't necessarily, kind of gung-ho on taking the lead, but they were better prepared to be at the table with us. And I'll actually pass it to Terrence Hibbard to talk more about through that process of what that looked like with them and other organizations. Next slide, please.
Yeah, hi everyone. I'll go quick because we only have a minute left, but just as an example, we found that Project AWARE, many of you understand what that is, came up as a grant opportunity. It's 4 years and I think 1.8 million a year. And it's really around providing mental health in school-based services. And so, our two, so we had to, and it came out in April, and we reached the Department of Education, and they weren't really able to apply at that time. And so when it came out this time, the deadline was tight. So we had to, not only did we reach out to our old contacts at the Department of Education who were interested, we also had to leverage our contacts at Families as Allies, the Department of Mental Health, and even within our own university to try and reach the head of the Department of Education to secure her support. And then that allowed us to kind of go through them to secure the department support. And then we're working with the school district that we chose for that grant is the Mississippi Achievement School District. And that's a district of schools that are, quite frankly, not doing so well. So they've been taken over by the state. And then what we did was we leveraged our relationships with other universities, and we're kind of gearing up to provide services to that district based on their needs and the needs of each individual school in that. Separately, the Department of Mental Health has also introduced us to the CMHCs that are in the area where that school district is, so that they can also provide more intensive face-to-face services. Next slide, please.
Just if you could share your final words.
Yeah. So each of the teams within have their own roles. And next slide. And then we had this last slide here for just who we are actually talking to. We thought that might be interesting for y'all. Who we're actually talking to in each of these departments, if you were thinking about reaching out. So just generally speaking, like our ability to reach out through the contacts we have to then push deeper into other organizations around the states, helping us to expand our footprint.
Great, thank you so much. Okay, I'm going to turn it over to the Montana team.
Yeah, hi, can everyone hear me okay?
Yes.
Great, thank you. So my name is Kat, and I manage the Montana Access to Pediatric Psychiatry Network, which we call MAPNet. So I've been in this position since March, so I'm still a relative newbie, but we have had some exciting developments that I'm going to share today. In the next slide, please. So MAPNet is a 2018 PMHCA awardee. And historically, just for some context, we've had a really difficult time maintaining partnerships due to several factors. One of the main ones just being staff turnover and that atrophy of relationships that occurs when you have gaps in nurturing those relationships. So our primary partners are the University of Montana Rural Institute for Inclusive Communities and Billings Clinic. And I will say that two of my coworkers are on this call, my counterpart at Billings Clinic, Kim Hart, and then our evaluator, Caitlin Fertali, who are wonderful. Next slide, please. So I understand that some of this information might be a little redundant for folks who have had longstanding existing partnership wins, but I think for some of the new awardees and some of those who have similarly struggled, I think there's a lot of value in this latest partnership win for us. So when I started in this role, there were not a lot of strong existing partnerships with outside entities. Our grant is administered by Montana DPHHS. And so travel and outreach had been inconsistent, which I'm sure a lot of people can relate to, just due to the composition of staff at the time and the impacts of COVID. So with turnovers, it left us in a place of little collaboration. So when I started my position, one of my primary goals was to leverage the reach and collaboration of our program. So I initially reached out to the president of the Montana chapter of the AAP, and that was just to introduce myself and the MapNet program, put a face to the name of the program, and then we set up quarterly meetings to discuss opportunities for collaboration and educational collaboration in particular. So through doing that, I was able to familiarize myself with their executive director and some of their leadership team. And out of this came the opportunity to collaborate on a CME opportunity for primary care providers. So outside of our project echoes that we do biweekly through Billings Clinic, and then we have a yearly mental health symposium, we have struggled to identify valuable educational opportunities that really increase provider capacity in treating children with youth and mental health needs. So what we did is we collaborated on a training called a REACH training, which will bring me to the next slide. So this CME event was championed by a pediatrician that was actually a member of the AAP who had attended it and really thought it would be a valuable tool for providers across the state. One of the goals of the AAP was to eliminate the funding barrier because it is quite costly. I'll get that into a little bit more later, and to provide this to providers free of charge because we felt like we would get better engagement and participation if that barrier was removed. So the REACH Institute, just for a little background, is a 501c3 nonprofit, and they focus on training mental health providers that are treating children and families. So through a joint collaboration with the AAP and the Montana Blue Cross Blue Shield and MapNet, we were able to offer, this is a mouthful, but the pediatric or the patient-centered mental health and pediatric primary care training, which we can colloquially call the PPP training. And that was actually just offered October 28th through 30th. We had 45 participants. So MapNet's involvement specifically, so this was something that the AAP was trying to do. And with our involvement, we were able to expand this registration past just the membership of the AAP. So the training occurred over the weekend and it was virtual. So it was a 16.25-hour interactive course, and it also has a 6-month follow-up program. So that follow-up program consists of monthly small group case-based learning, which is mediated by the REACH team. And as a little bit of additional background about the nuts and bolts of this partnership, so the AAP were awarded a $70,000 grant for 25 providers to attend this training, and that was through Blue Cross Blue Shield. So where we came in with MapNet, that number exceeded what we would have been able to contribute for our budget. But through our partnership, we were able to expand that to 45 providers, and our cost in co-sponsoring this training was $16,000. So we thought it was a really high yield opportunity to provide support and open this up to a lot more providers across the state at a cost that was relatively low to the initial $70,000 investment. And because it was initially just geared towards the AAP, through our involvement in this expansion, we were able to open that up to family providers and AAPs as well. And so then we distribute it out to our networks, and you can go to the next slide. As you can see, the training objectives for this particular CME opportunity really closely align with our grant objectives, just in terms of expanding provider capacity, in treating children and adolescents with these common pediatric behavioral health problems. So I'm not going to read all of this verbatim. I think that would be a little duplicative, but I will give you all a quick second to just review the objectives here, because I think there's a lot of value in this training and knowing that there's such a overlap in terms of the objectives. And I know we're all always trying to work towards educational opportunities. Okay, next slide, please. So I know I've already kind of gone over some of these top two bullets, but I also just wanted to throw in there that through our involvement, we were also able to do a presentation on the MapNet program to these providers that were participating in the training before the training started. So I hopped on, was able to introduce MapNet, provide all of the information and the website to everyone. We're getting the enrollment data from the AAP, and so we'll be able to reach out and then send some corresponding MapNet materials for those providers should they need them. And so we're really excited at the opportunity to connect with 45 people that are in this constituency base that we're trying to reach with the MapNet program. Next slide, please. So here you'll see the participant data points for the registered trainees. So you'll see of the participants, 65% were from urban areas and 35% were from rural areas, with the caveat that Montana is overwhelmingly rural. So in the last census, the largest city in Montana, which is Billings, had a population of 117,000. So it is relative, but we also were pretty excited to be able to reach some of these rural providers. That's something that we've really struggled with historically.
Kate, 2 minutes.
Oh, and while I was hoping to have the evaluation data and type of this presentation, I haven't received that quite yet, but we are really excited to just review that and assess the program's educational impact. And then we already have meetings set up with the AAP to talk about how we can be involved in training for school-based providers as well, and then maybe a future REACH training in the future. Next slide, please. So I'm not going to go super in depth into some of our other partnership wins, but we do have a lot of exciting partnerships percolating over in the MapNet realm. So all of these are nonprofit organizations that are working within the pediatric behavioral health landscape across Montana. Despite this, they haven't historically cross-pollinated with their work. So we're really excited to bring everyone to the table to just increase that exchange of ideas and collaboration beyond MapNet. Montana Pediatric is doing.
Is it? Oh.
Do I need to stop?
No, you can continue.
Oh, okay. So Montana Pediatrics is doing a lot of really exciting work in the integrated behavioral health, telehealth realm. So we have a project in the works with them, and then Catalyst for Change is doing a lot of exciting work in rural communities with community health workers, where they focus on having a trusted CHW embedded in a rural community to connect patients to resources. And then the Rural Behavioral Health Institute is doing a lot of great work in school screenings, and they have a child and adolescent psychiatrist on staff. So we're really excited to see how these projects can marry and see how we can also get into the school realm. I will save the in-depth information for another time after our expansion work plan is approved. And I have more than 10 minutes, but those are the things that we are excited about and have going on here in Montana.
Thank you so much. Okay, and last but not least here to share about policy and partnership wins is our Georgia program.
Hi, good afternoon and good morning to those who it's still morning time. My name is Josephine Mende, and it is my pleasure to be with you today and to share about our PMHCA program here in Georgia. I am joined by my colleague, Matthew Clay, who will be co-presenting with me today. And Matthew is the Director of Special Projects at the Georgia Department of Behavioral Health and Developmental Disabilities. So the name of our program is Georgia Mental Health Access in Pediatrics, known as GMAP for short. So throughout the presentation, you'll hear me refer to our program as GMAP. My particular position is housed within the Georgia Health Policy Center at the Center of Excellence for Children's Behavioral Health, which is housed within Georgia State University, just to provide a little bit more context on where I'm coming from today. The goals of our presentation today are to provide an overview of our program here in Georgia and highlight partnership wins and policy wins over this past year as PMHCA awardees. And Matt, I don't know if you want to introduce yourself quickly or if we don't see you yet.
Yeah, just real quick. Good afternoon, everyone. Thank y'all so much for the opportunity. My name is Matthew Clay. I am the Director of Special Projects at the Department of Behavioral Health and Developmental Disabilities, and am very excited to be here. Josephine?
Thank you. Next slide, please. So GMAP is a 2021 awardee. Our tagline is integrating behavioral health into primary care practice, which is very fitting for us. The Office of Children, Young Adults and Families at DBHDD is responsible for Georgia's system of care and children and families who are accessing public behavioral health system. The Office of Children and the Office of Children, Young Adults and Families partners in this work with Children's Healthcare of Atlanta, the Georgia chapter of American Academy of Pediatrics, the Medical College of Georgia, and the Center of Excellence for Children's Behavioral Health. And so that was just to kind of provide you an overview of who are partners in this work. Some of our partners, of course, there's so many more. And just to provide a little bit more context on the makeup of our state. So Georgia is very diverse. Hopefully you've made it down to Georgia. If not, please come and visit us. It's a lovely state. But geographically, we have 159 counties, including urban and rural. And of those 159 counties, 124 are designated as rural by the Georgia Rural Developmental Council. So that just kind of gives you an overview of what we're working with and how much of our state is rural. Essentially 1 out of every 4 residents resides in a rural area. And most of our state's rural counties are in the southern half of the state. And poverty is particularly prevalent in the rural areas of Georgia. And among those rural counties, 44 of them were defined as being in poverty. So this slide shows you kind of our catchment areas for the GMAP program. You'll see that we are in Regions 3, which is that Metro Atlanta region, as well as Regions 4 and Regions 5 of the state. Now, the Metro Atlanta region is actually one of the largest, it's the 9th largest metro area in the nation. So it's fairly large. And this houses about 57% of Georgia's entire population. So those are 2 huge areas that we're really focusing on for our grant. And of course, our focus population is primary care providers in Georgia, serving children and youth ages 0 to 21. Next slide, please. On this slide, I'll talk a little bit about our partnership wins, and then Matt will kind of talk a little bit about our system of care here. So GMAP partners with several agencies here in Georgia to bring this program to life. In addition to DBHDD, of course, which is our state behavioral health agency and the prime for this grant, our formal partners in the work are the Georgia chapter of the American Academy of Pediatrics and the Children's Healthcare of Atlanta, which is one of the nation's largest pediatric healthcare systems here. I'll speak first to our partnership with Georgia AAP. So GMAP has allowed us the opportunity to partner in this work with Augusta University, the Medical College of Georgia, and the Children's Hospital of Georgia. This was a huge win for GMAP and for Georgia because it allowed us to reach providers in the rural areas of our state in sort of an easy and accessible way, and really tailor the program accordingly. As I mentioned earlier, a lot of our population live in rural counties. Through our partnership with CHOA, GMAP has been able to expand the services of the teleconsultation advice line and expand the reach of who is accessing the line. So prior to becoming an awardee, the CHOA advice line really was operable only 3 days per week for 2 hours each day. Through this collaboration and this partnership, the advice line has been expanded to operating 5 days a week at 4 hours per day. So that's a huge win and a necessary adjustment as GMAP continues to serve providers across other regions of the state. This partnership has also allowed us to tap into the Children's Care Network, also known as TCCN, which is essentially a collaboration between a hospital system and independent providers to improve patient outcomes at a community level. I'll pass it over to Matt to talk a little bit about the system of care.
Great, thanks, Josephine. So yes, I do want to take a moment to speak about Georgia's system of care. For those folks who may not be familiar, a system of care is a spectrum of community-based services for youth and young adults who may have a behavioral health challenge and their families. The family is very much in the driver's seat, and the system, which could include service providers, stakeholders, pediatricians, they really work with the family and alongside the family to meet those behavioral health goals. Of course, all services are done in a culturally and linguistically appropriate way. And I think at the core of a system of care, it's all about collaboration, right? It's all about teamwork. And it was through a system of care expansion grant that really helped set the foundation for our work on the GMAP project. This included DBHGD's initial work with the AAP Georgia chapter. We initially collaborated with the goal of strengthening those working relationships between pediatricians and behavioral health providers. We had a number of key wins, largely predicated on that educational piece. We developed numerous access guides, educational materials, briefs, presentations. So again, just trying to essentially teach the right hand what the left hand is doing. Another outcome from our system of care expansion grant that has truly been beneficial for our GMAP work is our further collaboration and inclusion of certified peer specialists. These certified peer specialists, these are individuals who have lived experience either personally with a behavioral health challenge, that's a mental health challenge or substance use, or being the primary caregiver of a child who may have a behavioral health challenge. But it's been a huge advantage to work alongside CPSs and really gain their insight, both for GMAP as well as our other programs. Next slide, please.
Next, we'll highlight a few of our policy wins in the state. The first one that we want to highlight is the Mental Health Parity Act, which some of you on the call may have heard about. This was a huge win for Georgia. This also referred to as House Bill 1013. It passed this legislative session, and this legislation requires insurance companies to ensure parity between mental health and physical health care. And we all know how important that is, and for us in Georgia, especially because for the first time in Georgia, all health insurance plans must cover mental health conditions on par with physical ones. So patients can no longer be denied medically necessary treatment. Again, this bill was a huge win for us here in Georgia and for GMAP because it expands access to affordable mental health treatment and behavioral health services in Georgia for youth. And I'll pass it on to Matt to finish us off.
Yeah, definitely. So yeah, I think Josephine, I think you're spot on. And I'm sure I'm preaching to the choir when, those policy pieces, it really sets the tone at an organizational level. So I wanted to point out a couple examples. Again, pointing back to our certified peer specialist, Georgia back in 1999 was actually the first state to provide Medicaid reimbursement for peer services, or excuse me, for peer specialists. So since then, we've really strategically looked for ways to further codify certified peer specialists into our work. One of the key policies have been DBHGD acting as the certifying body for the state. So I just wanted to briefly share a couple of outcomes that have been attributed to this policy. One of which is really the State Department better working with family serving organizations. One of the key themes I know I've gotten out of this afternoon is how important that connection and collaboration piece is. And through these, deliberate policies, we've been able to really operationalize that. Another strategy I want to mention, and as I said, policy, I think it could be considered a kind of a top-down approach, right? But I wanted to mention our system of care website, which is admittedly more of a bottom-up approach, but a key win for our state nonetheless. our system of care website, the goal is to really take that system of care approach that's, again, is predicated on teamwork and operationalize that approach in a web-based format. Functions of our website include access points for families seeking services, key points of contact for providers and behavioral health providers, community service boards, training calendars, events calendars, digital library, just kind of a one-stop shop for all things system of care. And we just launched in August, but so far, we are seeing a strong ROI. Again, when you think about families accessing services, pediatricians, attempting to learn more about which providers serve their families in their communities, and ultimately just a stronger network at large. So I will encourage y'all to check that out. And with that, I believe that's our last slide. So I'll turn it back to the moderator. Thank y'all.
Thank you so much. Well, that was really great to hear about some partnership wins and policy wins, and definitely themes that we're going to continue to reiterate and share best practices on as the project goes on. I think we are joined by both the Federated States of Micronesia as well as the emergency services for medical emergency medical services for children. And so I'm going to turn it back to the emergency medical services for children group to give you an overview of their TA plan, and then over to FSM for an introduction. So while I'm scrolling backwards, hopefully that is okay for all of you. If the team from PMSC can hop on, that would be great.
Yeah, we are here. Thank you so much. And apologies that we weren't on at the very beginning of the session. I am joined by co-director for the EIC, Dr. Charles Macias, who's also on the call, but I believe in transit today. So he will probably not be chiming in quite as much, but we're excited to share how we a little bit more about the work we do and how we hope to be able to support PMHCA grantees. So if you can go to the next slide, please, which is just our standard disclosure and acknowledgements for funding. We're grateful to HRSA for, and nothing that we present is official views or opinion of U.S. government. So next slide, please. So much of the work that we do within the EMS for Children Innovation and Improvement Center and across the larger EMS for Children space, of which there are 5 other grantee programs that we help to support, is really to raise the bar in emergency care as a whole across the entire United States. And what we know is that over 80% of children are generally seen in community, rural, critical access hospitals that don't actually believe that's where the majority of children are seen, but yet collectively it accounts for over 80%. And when you look at each of these emergency departments individually, we know that the great majority see fewer than 15 children per day. And to date, there are no standard universal requirements that call out the needs of children when it comes to hospital licensing and regulation. So for the last really many years, and I would verge to say 35 plus years, although I have not been engaged for quite that long, the EMS for Children program has really been focused on improving what we call pediatric readiness and emergency care. And we do that both within the emergency department setting as well as in the pre-hospital setting. But I think for the purposes of this overview today, the focus is really on emergency departments. And our goal is to really look at a systems-based approach, how we can raise the bar to meet the needs of children. We have essentially worked with a number of national partners, the American Academy of Pediatrics, the American College of Emergency Physicians, and the Emergency Nurses Association to promote national guidelines for pediatric readiness, which are really demonstrated in the graphic here. And this is, as I mentioned, systems-based. So the idea being that there are champions on site, there are policies and procedures in place, there are safety measures in place, there's a quality improvement program in place, and so on and so forth. But suffice it to say that it's not just about having the appropriate equipment and supplies, but making sure that the entire system is ready to meet their needs. Go to the next slide, please. One of the components of pediatric readiness is absolutely focused on mental health care, and in fact really calls out the importance of having a policy or protocol in place to meet the needs of children who present to the emergency department for mental illness. And I know that you all are very aware of the epidemic impacting our children's youth, but specific to emergency care, over the last decade leading up to COVID, we saw a 60% increase in all pediatric mental health visits to emergency departments specifically, and even higher increases when it comes to deliberate self-harm and or substance abuse issues among our children's youth. And when COVID hit, we saw significant decreases in the number of overall pediatric visits, none more so than those under 14 years of age. But even within that, we saw an increase and an uptick in the number of ED visits for mental health. And in particular, low volume and rural EDs are experiencing even a greater strain on this, with a 12% increase in pediatric mental health visits. So we know that that is a real area of focus and need, given especially that they have lower resources, often fewer resources and access to pediatric mental health care experts. Next slide, please. So because of this, children continue to present to emergency departments not having necessarily ongoing mental health access points outside of that. And this has led, as many of you are probably aware, to ongoing issues of boarding. There have been a number of publications in the layperson media about stories related to this boarding for 10 days, 3 weeks, 5 weeks, so on and so forth. And it really puts a strain on these children and their families. And it really highlights, in addition, the lack of resources in mental health, but also the lack of coordination of care to support these children, both before they come to the emergency department and also after they are ultimately discharged from the emergency department, whether it be to an inpatient facility or an outpatient resource. A couple of years ago, within the EMSC Innovation Improvement Center, we launched what we called a telehealth quality improvement collaborative. And we really focused on growing telehealth capacities across states and territories. We had 8 states and or territories participating in this work, and really looking at how they could better support the needs of children with either mental health and behavioral health emergencies or special healthcare needs. Through that process, we created a telehealth toolkit to support emergency care and grow that capacity. But we did find that there were a number of ongoing challenges, including funding, ongoing support within the facilities and among staff and personnel, and then of course, reimbursement. Next slide, please. So what we do within the EMSC Innovation Improvement Center is we try to utilize quality improvement science as the underpinning for our work. We know that through quality improvement science, we can more rapidly drive evidence into practice. So if we waited for evidence to be passively taken up into practice, it takes on the order of 18 to 20 years, whereas through QI efforts, we can really push changes into practice on the matter of 3 to 5 years, and sometimes even more rapidly than that. Through our work, we host a number of large-scale national quality improvement collaboratives where we bring together institutions and frontline workforce healthcare providers who are working collaboratively to make improvements in their care processes by integrating that evidence into practice and going through even systems-based change strategies. We also work closely with a core knowledge management team where we're really trying to drive knowledge translation by pulling out tangible elements of evidence, transforming that into something that's more digestible, and disseminating that through resources and toolkits, which we now have a number of on our website. And then lastly, we really focus on creating partnerships on a national scale, not just to align priorities, but also to ensure diverse and critical perspectives are achieved. And that includes the perspectives of families and the children. And our ultimate goal is really to improve access to high quality healthcare services across the entire continuum of care, of emergency care, from the pre-hospital to the hospital-based setting and back to the medical home. Next slide, please. What we hope to really support through this program is partnerships between PMHCA programs or grantees and the emergency care space by really beginning to identify some of the barriers to being able to provide support to the needs of families and providers in that space, to help develop evidence-based tools and establish regional partnerships with emergency departments and emergency care providers. And we hope that through this work, we'll be able to provide proof of concepts when it comes to implementation of these efforts. What you see depicted on the bottom of the screen is really a staged approach of the behavioral health care continuum. And we plan to focus really on these three boxes that are highlighted in yellow of how we bridge these acute intensive services, i.e. emergency care services, with resources in the outpatient setting, including PMHCA programs, but also resources within the medical home and primary care providers, ultimately to increase mental health accessibility and improve integration. Next slide, please.
2-minute warning.
Thank you. So our plan is to really walk through a few phases. We hope to engage 10 regional teams and really walk through an environmental scan to understand those barriers, begin to work through focus groups to identify strategies for best practices and implementation, and then support teams with actually implementing some evidence-derived approaches to integration of PMHCA programs into the emergency care space, ultimately creating a centralized dissemination plan and resource tool. Next slide, please. So as I mentioned, we do spend a lot of our time focused on building out centralized resources. We have implementation guides that we use for our QI collaboratives. We have a number of toolkits on our website, some of which you can see depicted here. We build together assessment tools and environmental scans with participants in our QI collaborative work, and we really try to share these best practices. And you can see on the right-hand side some of the areas of focus that we know have been barriers in the past to implementing telehealth programs within emergency care settings. Next slide, please. Currently underway are just beginning to start as a registration for what we call the ED Stop Suicide Collaborative. This is a collaborative that we now have open enrollment for emergency department-based teams to enhance their clinical care processes for suicidality. And we intend to enroll as many as 150 to 500 ED-based teams across the country. Their work it focuses primarily on enhancing their internal clinical care processes. A core component of their work will be learning how to develop partnerships and leveraging regional resources, which by all accounts includes the PMHCA programs and grantees. If you go to the next slide, please. We view this as a real opportunity to help bridge those partnerships with these teams that are enrolled in our ED Stop Suicide Collaborative. And we hope that we can do that by developing regional partnerships, by helping to connect PMHCA programs with the EMSC state partnership program managers, to leverage the participants that are in this ED Stop Suicide Collaborative, and then also to support collaboration with primary care providers, the medical homes, and families. Next slide, please. So we hope that together we can come up with some solutions that are integrative of primary care, emergency care, and community partnerships. We know that it's going to take an iterative approach to ensure that these are innovative, sustainable solutions that meet the needs of everyday technology. And our goal is really to provide that technical assistance by not just bridging partnerships, but also creating these evidence-based tools that can be adapted to fit regional needs and regional programs. So I think that's all I have for today. Thank you.
Thanks so much, Kate. Okay, wonderful. And for all of these technical assistance providers that you heard from today, we'll connect the awardees with the TA providers as this expansion effort kicks off. And I will turn it over to FSM. Okay, and someone is phantom controlling the slide, so that's great. Thank you so much. The Federated States of Micronesia will introduce themselves and their project, and then we will turn back for some questions and some thoughts from you.
Thank you. Can you all hear me?
Yes.
Okay. Greetings from the Federated States of Micronesia, or FSM. My sincere apologies for hopping on really late, but I thank the PMHCA team for granting me the opportunity to introduce FSM. My name is Sherlyn Reynolds, presenting on behalf of the Program Director, Mr. Benito Victor of the FSM Behavioral Health and Wellness Program. FSM is one of the newest recipients of the PMHCA Award. In fact, this is our program's very first HRSA award. So we understand that there's a lot to learn, but we're very excited to be working with Cara, Matavi, and the PMHCA crew. Next slide, please. Our project location will be at the 4 states or islands: Bushay, Pohnpei, Chuuk, and Yap. For those of you who don't know where FSM or Micronesia is, it is located in the North Pacific between Hawaii, Guam, and the Marshall Islands. FSM is made up of over 600 islands and has a landmass of less than 500 square miles, but over 1 million square miles of ocean. Picture this in your head and you'll understand why we need this award so much. Next slide, please. Yeah. Oh, next slide. Okay. Our PMHCA project key staff will be implemented by the following. So our program director himself, 1 project manager, and 4 counselors with 1 at each state. These staff will be supported by me as the fiscal staff, as well as the data coordinator for the BHW program. Next slide, please. As I mentioned before, FSM is made up of mostly ocean, which means limited accessibility to basically everything, most especially healthcare. That is why we have 3 goals to implement under the PMHCA award. We plan to increase availability and accessibility of statewide and or regional networks of pediatric mental health teams. We also plan to develop and enhance existing mental health programs in the islands to facilitate consultation support to pediatric mental health care practices. The last one is we plan to provide training and technical support or assistance to the pediatric primary care providers to support early identification, diagnosis, treatment, and referral of children with behavioral health conditions. We trust that with the full support from the PMHCA team, the team, and everyone else, our partners at the state levels, this project's implementation will be successful. Thank you. That's all I have.
Thank you so much, Sherlyn, and for hopping on at a challenging time. Okay, we're gonna I'm gonna scroll to just a little brain break while you've heard so much. Sorry about this if it's making you dizzy. As you heard, we're going to convene in person in March of 2023, March 27th through 28th in the DC area. And we've already started convening a group of internal leaders from your states and your programs that are working to inform the agenda for our in-person convening. But as many of our technical assistance providers mentioned today, we want to make sure that the content is driven by you and that it is most useful to you. So many of your colleagues are represented on that internal planning team, and we'll also have the expertise of our TA providers. But just wanted to, as you reflect on today's very rich webinar and what you've enjoyed hearing about, and as you're thinking about growing or expanding your program, or still, in your first year or in your second year of awards, or if you're in your 3rd or 4th year of awards, looking to see, what you'd like to see at our 2-day in-person convening. So if you've heard something you like today, if it inspired you to look into something for your program, please drop some topics in the chat that you want covered in that in-person convening. So topics you want your peers to speak more about, things that are challenges for your program, best practices you'd like to share, any working sessions you'd like to have, or resources that you need. And we know that these requests are also coming through your NCC reports and through your expansion proposals. But if anyone has an ideas at this point in time, please share them in the chat, as they'll help us populate an agenda that is helpful to you all. And with that, while you are thinking, I'm going to turn it over to Patrice, who will open it up for questions and answers.
All righty, so we got through everything. And definitely want to thank all of our presenters for sharing some really fruitful and valuable information. Hopefully you all felt as though you gained something or learned something that you'll be able to incorporate into your programs, or at least gained a new partner that you may reach out to get some insight into the work that they're doing. But we are now going to open it up for Q&A. So if you all have any questions that you would like answered on today's webinar, please feel free to enter them into the chat or to take yourself off mute if you dare. And these could be any questions. It could be related to the presentations today, or if you have any other outstanding questions related to your base or expansion awards. And if my team can help me with monitoring the chat, if anything comes in. Now, where's the chat?
Nothing's coming in right now, but maybe if everyone wants to take a 1-minute stretch break while you're thinking of your questions, and either put questions or topics you'd like to see in the chat, that would be great.
So while we wait for questions to come in, we do have some topics that have been shared. So a workshop topic related to better working with individuals with lived experience could be fun. So thank you, Matthew. Rachel shared that an award meeting topic related to sustainability tips. So best practices in advocacy to develop legislation supporting PMHCAs. Would like to hear more details from Washington, Rhode Island, Massachusetts, and the KV Foundation. Thank you, Rachel. And then Stacy just shared that the KV Foundation may be a good breakout to help people with funding options. Thank you, Stacy. Katie mentioned that she would like to hear more about staffing models based on population, demographics, etc. And then Stacy mentioned also data management systems. Any other ideas, recommendations, and/or questions related to your PMHCA awards? Thank you, Sarah. So Sarah mentioned that she'd like to learn more about evaluation efforts in other programs. It's a good idea. Alrighty, hearing no other input. If you all think of anything, oh, here's a question. Thank you, Sherlyn. When will the info on data management reporting tools for PMHCA be shared? Kara, do you want to chime in?
Sure, thanks for the question, Sherlyn. At the minimum, we share them 30 days before the due date. So as a new awardee, I believe your first due date is January 28th. So at the latest, we would share guidance by the end of December, but our plan is to share guidance with you within the next couple of weeks.
Thank you, Kara. Okay, we have another question. How can PMHCA programs fit into the community school model and not just community-based health centers? Does anyone from my team or someone from the School-Based Health Alliance want to chime in?
Hi, this is Katie from the School-Based Health Alliance. We would be happy to talk with you more about the community school model. Actually, the head of that organization is on our board. We do a lot of collaboration. Seems like you probably agree with us that school-based health centers and community schools are a natural fit, and a lot of our work overlaps. So happy to take a deeper dive on that at these next sessions. So Jordana and folks, maybe just let us know how we can be of service there. Certainly a good topic.
Thank you, Katie. I think we have someone else that is also interested in connecting with the School-Based Health Alliance. So like Jordana mentioned, we are hoping over the next few weeks to make those connections with all of our TA providers. And so excited to see that some of you have already seen the value in being able to connect and partner with our new TA provider. Okay, we have a comment from Eve Bills. She said, South Carolina doesn't have a state affiliate with the School-Based Health Alliance, and I'm wondering what this partnership would look like. Is there a good person to contact?
Yeah, so I would start with us at SBHA. We when there isn't a state affiliate, we kind of search our network and try to make sure that we have some contacts in those states. So different states have different units, all a volunteer network. And so different states have different resources that way, but happy to, if you, again, I'm not sure of the format, you're welcome to email me or follow the format for accessing TA via MCHB, but we're happy to connect you. So once the kind of system is in place, we can definitely try to make connections wherever any of you exist in different states, and then connect you to affiliates and state program offices if they exist there. And if they don't, try to find some good contacts that are like working in SBHCs or other connections there. And again, SBHA's focus is school-based health centers, but we obviously believe that we're part of a spectrum of care and want to connect you to whatever models make sense. So it might be the community school model, might be a comprehensive school mental health program, different resources that we hope will support your work. And I see a couple other comments in the chat as well. So yes, let's definitely connect. We are ready and willing to help.
And I just wanted to know, we are still working through internally, like the TA protocol for requesting TA. And so once that's been developed with each of our TA providers, we'll be sure to share that with all of the awardees so that you're clear on how you can access the services that'll be available to you all. But yes, we'll definitely make note of those that have already requested a connection with the School-Based Health Alliance. And I see Susan has another question related to whether there's any connection between the School-Based Health Alliance and the Smart Clinic model.
I'm going to admit that I am Googling Smart Clinic model. Do you want to tell me what that is, Susan?
It is a model of school-based clinics that I've encountered here in Alabama. There are, we're partnered with some of those clinics in a western region of our state, which is a very rural, underserved area. They have 5 school-based clinics within one of the county school systems.
Okay, gotcha.
So it's just a model framework, I guess, for school-based clinics. And they have,
oh, go ahead.
well, I was just going to say, I know with the ones we partner with, they have pediatricians, family practice folks, nurse practitioners, and social workers.
Okay, cool. Now that you talk about it, I do think that we are familiar with that model. My colleague Paula, I believe, has worked with that model before. So I guess that's another thing to know about us. If myself or Laura Hurwitz on this project can't connect you with the right resources or aren't familiar with the models you're talking about, we will certainly tap the rest of our staff who have very broad experience nationally, urban, rural, geographically, all over the country with different models. So we can definitely find out more and figure out good ways to support you.
Thank you, Katie. We have one other question from Terrence, and it's, will the Innovation Center be looking to understand common areas of struggle between the PMHCA programs, or will it focus solely on mentoring? So Teresa, I'm not sure if you're still on the call. Or if anyone from the TA Innovation Center is still on the call and would like to provide a response.
I can speak to the the MSC Innovation Improvement Center, and we will certainly be looking at the challenges that PMHCA programs are facing so that we can identify some common challenges that can be better addressed. So it's not simply just mentorship and support, but really trying to overcome barriers.
And this is Carrie from the TA Innovation Center. I did try to respond in the chat, and I think it's a great question, and just wanted to note that it'll be kind of a both and. So looking at individual needs and being responsive to those, but also leveraging the opportunity to address shared challenges through a combination of peer interactions and trainings and with subject matter experts and whatever might be the best fit to address those shared challenges.
Thank you, Kate and Carrie. But yes, wonderful questions. Any other questions? And hearing silence, we can go ahead and conclude our Q&A session for today. But I did want to just share, of course, if you think of anything following the conclusion of our webinar, feel free to reach out directly to your project officer. And that goes for any ideas for our annual meeting in March in Rockville, as well as any lingering questions that we were unable to answer today. So I will now turn it over to Kelly Hughes to close us out.
Thank you guys so much for participating in today's half-day quarterly webinar. This is the first time we've kind of taken up half of your day to kind of meet and convene in lieu of meeting in person. However, we're now looking forward to meeting and seeing all of you all in the DC, Maryland area early next year. Hopefully the weather will cooperate. But again, want to thank you guys so much for joining. Special thanks to our presenters, especially our PMHCA programs, who are always have a willingness to present and share their successes, their challenges, and just collaborate with others. Also want to thank our MDRBD colleagues who may still be on and who jumped on to kind of hear the session from the Rhode Island teams. And also special thanks to our TA providers who you guys got a chance to meet. We're looking forward to providing more information about the TA centers moving forward. Congratulations again and welcome to our 5 new PMHCA awardees. We welcome you. I hope you felt the warm welcome today. And then want to also thank the PMHCA project team, Kara, Madhavi, Jordy, Patrice, and Katie, who will be returning back from maternity leave in a couple of weeks. And as Patrice mentioned, if you have any additional burning questions or suggestions for the upcoming all-awardee meeting, please feel free to reach out to your HRSA project officer. And so we hope that you guys enjoy the rest of your afternoon, and thank you so much for joining.